Well, good morning, everybody. We are now live and we are quorate, which is the good news. So welcome to the Health and Wellbeing Board. Before we start proceedings, may I bring your attention to some housekeeping matters. There is no expected fire alarm test today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. I think the word is follow the officers, they'll know where they're going. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Warspite room and during the course of the meeting, committee members are consenting to being filmed and to the use of the recording for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants can hear. And that it's switched off when you're not speaking. Your mobile phone needs to be turned to silent, please. And I think then if we go around the room and introductions happen, that will help matters. Karen, do you want to start?
I do. So I'm Karen Pilkington and I'm here from Plymouth Octopus.
I'm Councillor Jemima Lang. I'm Deputy Leader of the Council and I have the Children's Social Care, Comms and Culture portfolios.
Gary.
Gary Warbridge, Strategic Director for Adults, Health Communities, Plymouth City Council.
Elliot Werngould, Democratic Advisor to the Health and Wellbeing Board.
Steve Madden, Director of Public Health, Plymouth City Council.
Mary Aspinall, Chair and Councillor for Sutton Mount Gold, but I also have the portfolio for health and wellbeing, etc.
Good morning, Councillor Andy Lugger, Leader of the Opposition and Vice Chair of this board. Thank you.
Have we had any apologies? Oh, sorry. Let's go on. Let's go to the screen. You'll move around as I try to call you to say hello, but let's just give this a try. Tony.
Hi, Tony Gravitz, Manager for Healthwatch Plymouth and Systems and Intel Lead for Healthwatch Plymouth, Devon and Torbay.
Right, Rob.
Yeah, good morning everyone. Rob Smith, Chief Executive, Improving Lives Plymouth and Chair of the Wellbeing Hubs.
Michelle.
Hello everyone, it's Michelle Thomas. I'm the Chief Exec of Live Well South West.
And then our presenters for in a minute, we'll ask them to say hello to you all now. Ash.
Ash Trivedi, one of the directors and health integration partners.
Phil.
Phil Hope, one of the advisors to Health Integration Partners. Pleasure to be with you this morning.
And last but not least,
Hi everyone, Rhoda Franconia, Senior Consultant with Health Integration Partners.
Thank you everybody. Right, I've had a message from David Haley to say he was at a meeting that was finishing at 10, so he was going to hot foot from Ballard House, so we will be expecting him in a bit. Okay, are there...
Did you do Michelle? Sorry.
Yes.
Oh, sorry.
Yes,
sorry.
Michelle.
I missed that. Sorry,
Yeah.
Michelle. I could see you there, but I didn't hear your name out, so apologies.
Oh, thank you. I'd have done it twice.
Thank you. So I've had apologies from Laura Alexander, and just to advise that Councillor Nicholson is no longer able to sit on this committee, so he will not be here. Declarations of interest? Anybody? No? You're all happy? Good. I have no urgent business, so I can move on to item 4, which is the minutes. Are we all happy with the minutes? And I would like to propose we agree the minutes as a correct record. Can I have a seconder, please? Andy, thank you very much. And then I'll ask you all to, do you agree? Hands up, please, if you do. Thank you. Excellent. We've had no questions from members of the public. So we'll move on to our first substantive item, which is conditions of success. Now, we've got an hour for this, so we really need to be following and whatever. So if, I don't know how we want to play this. Ash, do we want to have questions as we go, or do you want to wait till the end of the presentation?
It would help if we could do the presentation and then, of course, have questions, but also we would want questions from our end to be posed to the members of the board. So if that's okay, we would go through the motions first with our presentation and then get into discussion mode.
Well, the floor is yours.
Thank you very much. Great. Well, in that case, I will share some slides and that will just help up. So give me 1 second. And just before I proceed, can I check if you can see the slides clearly on your screen?
Yes, we can see them.
Brilliant. Thank you very much. So as you said, we have an hour and we are utmost grateful for the time that you're given. And I hope this adds value to the board's thinking and how you proceed forward with a very important topic, neighborhoods. Just before we get started, I know we did a very brief introduction about us and we have met a few of you one-to-one, but it might be helpful for the board to understand where we are coming from. So we are health integration partners, a very clinically professionally led firm. And the reason I stress on that aspect is because we all come from the coal face. We bear the scars, we understand the emotions, and hence it's important that there is a level of, I would say, trust and credibility in the way we operate with systems. We have been commissioned, this piece of work has been commissioned by the Department of Health and Social Care in conjunction with local government association. And the fact that it's joining hands at that top tier level implies the importance of health, care, and communities working together to support the agenda of neighborhoods. This next hour is all about you, to be honest, and how the board brings the right level of leadership across the system to support this very important aspect of neighborhoods. We're breaking this thing down in kind of 3 parts. The first part, I want to give you an introduction and give you an overview of this program and what we have done and what is the concept of when we talk about conditions of success, what does that really mean? We will then take you through the findings, many of you, and thank you for completing the survey. And we have found that very helpful. So this is our time now to present the findings back to yourself. And that includes the quantitative survey results, but equally importantly, the qualitative aspects that we have grabbed or corralled through multiple interviews and our observations. And then the third part, which I think is going to be very important, is really asking you questions around your priorities on the basis of what we have fed back to you. And hopefully we can start to think about our roadmap and how do we address that in the year going forward. So if that's okay, and if there are any immediate comments, I'll proceed with the introduction. So the 10-year health plan is I'm presuming everybody's aware of it. NHS England published it in July 2025 after a significant engagement across the country. And the 3 things that came out very strongly were the 3 shifts, the left shift, as they call it: hospital to community, analog to digital, and sickness to prevention. And the expectation is that the health and well-being boards, in alignment with their local strategic direction of travel, do embark on these 3 shifts and ensure that there is strategic resonance in the way you operate across the system. As a matter of fact, when we look at your health and well-being strategy, your JSNA, and your priorities, they are fairly attuned to the national direction of travel, and they do reflect. And we have seen a lot of systems, and I do want to compliment in the way you have been thinking about your strategic direction of travel is around really looking at the prevention, the health inequalities, the community-based care, triggering the lifestyle behavioral change, and then around an aging population. In many ways, what you are trying to achieve is not medicalize the entire approach, but actually to think about the very determinants of health and how we can start to really address the root causes. We have in really understanding your readiness of the system. We have connected with many of you, and you can see there is a list on the right. If we had more time, we would absolutely love to connect much deeper, much broader. Sorry, is there a hands up?
Yes,
Michelle?
sorry, it's Michelle, and I just wanted to add that Live Well Southwest as the community provider for mental health, social care, physical health, learning disabilities children has not been interviewed as part of this.
Fine, Michelle, thanks. And we will make a note of it. And then we may need a separate discussion with the board and the chair and how we address that. But thank you for bringing. And I said that, I know that in the short time, it was impossible to connect with literally everybody. So here is the list. And of course, if you find any obvious gaps, do let us know. And we have had a response to the survey that we have sent, and you can also see it has been responded by members of the Health and Wellbeing Board, the Local Care Partnership, and people belonging to both the partnership forums. And this report, in essence, is a synthesis of our engagement, the survey feedback, and learnings from other systems to support you in the readiness to the neighborhood health planning. And now I'm going to get into exactly what this is. But before I get there, it's important that we just reinforce or reiterate the role of, or in fact, the evolving role of the Health and Wellbeing Board. It's no news that Health and Wellbeing Boards are expected to lead the system. They are expected to align the system plans and ensure that there is alignment with the very direction of travel, which is heavily influenced by your health and well-being strategy. There is an expectation that the board will convene and coordinate cross-sector collaboration. And it is critical, that third bullet point, because in the absence of any facilitation within the system which does bring all partners together in establishing some level of shared accountability, I think the board has got a huge role to play there to establish, and that is where come the fourth bullet, which is around strengthening that level of governance and system shared or unified accountability. Expanding the inclusivity and representation, and that does not stop with just the statutory partners. It does include your voluntary sector, as well as people in establishing the democratic accountability that you uphold. And of course, you drive integration and collective ownership. Easier said than done, to be honest. They're all, fairly significant aspects and very cultural too, in many ways. But we wanted to emphasize that the evolving role of this board, especially in the concept of neighborhoods, is not just advisory, but foundational. You genuinely have to be acting as the democratic system-wide steward of the neighborhood health improvement, and that is beyond your statutory functions of overseeing the prep of GSNA, health building strategy, and the other things. And I do think this will be helpful for you to ponder in terms of how do you really, this one page is a whole constitution in itself. How do you actually do it? And are there X number of meetings that you hold in X number of hours that you sit down and discuss? Is that enough? So it's a challenge. It's a thing, something to ponder. And that is where I think our next slide starts to bring you, starts to describe some of those things. So just from a neighborhood perspective, there are implications, of course. I've just discussed the implications around the Health and Wellbeing Board around leading that process, driving integration and encourage inclusiveness. And it is important. But we, of course, have got expectations and implications across the system, which does include elected members. It includes the senior officers who are heading various organizations, and general leadership behaviors are expected or required. So this conditions of success tool that we have been using, in essence, is a way to understand your state of readiness, more from a cultural perspective, more from a hearts and minds perspective, and really understanding whether your governance structures, the way you make decisions, the way you discuss, and the way you operate as a board and as a system leadership, does that really work? What this tool is not is I just want to be clear, it's not a sort of a performance kind of tool. This is more a self-reflection tool. So you have been sent the survey, and I won't delve into this because this was sent to you. So hopefully you have understood by virtue of just filling the survey itself. But a very quick gist overview. This came from the MIT Center for Organization Learning. There are many such frameworks. This is just one of them, and it seems quite apt, especially in the context of neighborhoods, where you expect any system to have, if to operate, has to have the right quality of relationships. And within relationships sits the questions whether you have got the right people in the room, and are they in the room, or are they really participating and influencing being in the room? So it's quality of relationships. The quality of thinking, does it allow you to really think about all the perspectives, and is the quality of thinking really thinking about creating the best opportunities to improve outcomes? The quality of actions, and within that sits accountability. Is it all about actions and then you close the meeting, or does it drive some level of accountability from within the system? And the quality of results, how are you observing the results, monitoring, measuring, and responding to that? So I'll pause here and I'll hand over to Radha to talk about the results that we have received. And in doing so, because we are doing this across the system, hopefully we'll also be able to give you a sense towards the end around how you differ or are similar to others. And of course, we'll have subsequent discussion. Radha, over to you.
Thank you, Ash. We thought it might be helpful just to take you on the journey. We appreciate that this has been a very short, sharp, focused piece of work to really support you in thinking about different facets and making sure that you are ready as a system. So there were briefing sessions held sort of earlier on before the survey was instructed, with a 2-week window for completion. We were able to speak to a very small subset of people purely because due to the timescales, we just needed to focus in on 3 to 5 people and really understand some of the depth behind that, in addition to the survey results. But the second part, the part after us describing the results, is really an opportunity for any members who haven't had a chance to fill in the survey or be engaged with to really reflect on whether, one, this is a true representation of your results, if there's any gaps around those. And that's why today's session also does inform what this final report looks like as a sort of tripartite approach. So really what we're going to do next is take you through some of that survey feedback, and then the latter part of the session will be an opportunity to really reflect on and add to that substantively. So if we go to the next slide, please. So the first area in terms of the conditions of success was around the quality of relationships. So what was really interesting, and we've seen this, we've looked at the survey results, across the 5 systems that we're working with and wider, and really what we're getting here is quite a mixed message of the quality of relationships being rarely true and also consistently true. But the kind of key headline that we've understood is that there is a goodwill and strong base of collaboration, and there is an opportunity for those relationships at the board level to become more inclusive, better connected across primary care, local authority, the voluntary care sector, and health partners. And some of the kind of ethos that sits behind that is that Plymouth has a lot of talented leaders in the system, and there's been a lot of goodwill and partnership intent to build on. But that real conditions for success will depend on broadening representation, improving that executive engagement, and creating a safer and more equal condition for challenge across different partners in the system. So respondents describe relationships as constructive, with challenge positively received and community voice having some influence. But in terms of the kind of key representation missing as part of that, some people described that challenge is hard to raise, and especially voluntary care sector organisations or clinical perspectives often feel insufficiently heard. There was a key message that the voluntary care sector voice is valued, but there is a thing around fighting for that space and understanding that the real understanding behind community organisations, the makeup on them, and that there's a diverse section of representation that's expected. So it's what sits behind and enables true strategic partnership from the voluntary care sector. In terms of the primary care representation, this emerged as a major relational gap. So having the right people around the table, beyond GPs as well, thinking about primary care in its entirety. But then thinking about meaningful clinical input, that GP leadership, and an infrastructure body that's able to represent primary care in the right way. There was some threads around the local authority and health and wellbeing boards voices not fully included in some of the health conversations as well. And a real want to make sure that neighbourhoods are shaped from all lenses, not purely from a medical perspective. So there was something around that deliberate membership design. So what does the membership design look like that really facilitates this? And if we now move into the second condition, please. So the second condition was around the quality of data-driven decision making. And again, you can see that there's rarely true and consistently true, and parts of that has come out in the responses where there are pockets of strong analytical thinking, but it's around how data is really consistently joined up, trusted, or used in a way that genuinely drives shared priorities and informs system decisions. And some of the key ethos behind this was around Plymouth doesn't simply need more data, but it needs better shared interpretation, a stronger synthesis across organisational boundaries, and a more fully use of lived experience and clinical insight, so that data really does support those agreed priorities and real decisions, rather than that style of passive reporting. So some respondents said that data and insight are used well, but others felt that there is a lack of coherent data sets. So there's something missing in terms of how a consistent view of this is achieved. People did point to the absence of shared strategy or a single version of truth with clear priorities, making it difficult for data to do its job. But I'm really noting that on your agenda today, you have got a real strong version of what that looks like. So I think there is something about recognising that Plymouth seems quite aware of this, and has been doing some really excellent work to make sure those priorities are very clearly outlined and have a clear thread from strategy to delivery. There's an appetite to use data more strategically, so using things like outpatient demand, follow-up patterns and inequalities, and voluntary care sector partners suggested use of things like qualitative inquiry and peer research to really surface information from lived experience. And the last point really here is about ensuring the right voices are in the room when evidence is discussed. It's not often about making sure it's the person with the most experience contributing towards a conversation, but it's making sure that everybody has an opportunity to share their voice in an informed way, so that often different things are thought about. So there's a genuine partnership approach to that quality of decision making. If we could go to condition 3, please. So now that we've thought through the relationship and some of that in terms of how it informs decision making, the next step is really about how that translates into action and planning. And the kind of headline message that we received as part of this is around really the roles and responsibilities across different forums, so that the Health and Wellbeing Board is really able to take on its new responsibility in that real shift from statutory functions into that leadership role, and have more purposeful, coordinated action as a result. So Plymouth's action challenge is less about willingness, because we've understood the willingness in the system, but more about clarity, structure, and alignment, and really about how the different facets of the system join together around neighbourhoods so that decisions, delivery, and accountability sit in the right places. And some of that was reflected in, you know, Plymouth's the perception of Plymouth's Health and Wellbeing Board more as statutory, while the local care partnership is seen as that sort of more formal delivery engine. So that creates important governance nuance, but it's about the expectations around roles and responsibilities in different forums to be more visible and understood in the system. Some people have also sort of kind of reflected the need for an organogram or a governance map, but we are recognizing that currently, you know, the system is in a shape of, well, nationally, the landscapes are shifting, especially there's a big shift in the NHS landscape. So it's really understanding that and understanding the Health and Wellbeing Board's role, its intentional purpose, and how that really translates across the system in expected behaviours. And then if we go to the condition 4, please. So condition 4 is really about how do we embed this? How do we really look at those measurable results and sustainable improvement? And we can see that there's a clear, if you see the rarely true and the consistently true and how that feeds through the 4 sort of diagrams that you've seen, there is a real message around that clearer line of sight from strategy to measurable outcomes with realistic priorities, strong accountability, and that confidence that the board's activity is changing what happens on the ground. And again, I'll reference that you have got clear priorities coming later parts of the agenda today that start to address some of these messages. But the responses show divergence, and that some people think that there's increasing focus on outcomes and it's started to shift in that direction of travel. That current strategies, whilst they're broad, need to be broken into smaller, more practical aims, focusing on smaller priorities in the year that the Health and Wellbeing Board can have genuine ownership of. And considering where the board's real influence is in, thinking about oral health, cardiovascular disease, and integrated neighbourhood teams. There's been some voluntary care sector feedback in this space that measurable change often does come from that small scale, understanding what that co-production looks like, building on real system learning, and being able to scale or scrutinise to see what's working well and what's required to improve. So I've given you some real kind of depth behind some of the responses that we've received so far, but I'll hand over to my colleague Phil, who's going to take you through some of those headline messages for Plymouth, and then we'll take you through an exercise of reflection.
Very much, Ryder. And just to say, by the way, my name is Phil Hope. I'm one of the team, as I said. My background is that I was been a former councillor, member of Parliament, and I was the Minister of State for Care Services many years ago. And I've been working with the health and social care systems across the country since then, and very much been involved with all of the analysis and work that Ryder has just been taking you through. And just some of these headline messages, and then we'll have a chance to reflect on these yourselves. So clearly a real willingness among all you all to improve, and people seeing this as an opportunity for resetting and then co-designing and getting a much clearer shared purpose for the board. So these are the few, we pulled these 7 out as being the big picture, big ticket items that we think really are the priorities for you going forward. Firstly, the government, the governance and the clarity of that governance, and the relationship between the various parts of the system and where the board sits in relation to those. The need perhaps to have that clearer in the way that Ryder was already alluding to. Secondly, and I think this is true of every health and wellbeing board, a real move from the role you've had to date in terms of perhaps a lot of signing off of material that's been sent to you and discussing that, to one of leadership and action and oversight being championed by the chair. The system feeling, as you said to us, sort of structured for passive receipt of things rather than active leadership of policies or programs or ways of working. There's certainly good, strong relationships between you operationally and strategically, but we do see the evidence of the irregular attendance and sometimes the people that have sent because somebody can't go and somebody else to go in their place, not really reflecting the importance and the effectiveness of the board, although relationships are good. And a couple of specifics there. I think, Rada, you've alluded to this already. The primary care representation does seem to be a major structural weakness for you at the moment. Of course, that's exacerbated by the fragmented infrastructure and the neighbourhood boundaries not being aligned up between various parts of the system. But that is going to have and is having a direct impact, therefore, on the tangible kind of delivery of the neighbourhood approach. Also, there's very much an enthusiasm among you for addressing the wider determinants of health, the Marmot style approach. But to do that, the board membership needs to be right and to have that broader strategic lens as a board. And the involvement of the voluntary community, faith and social enterprise sector, people with lived experience, is seen as valuable, but it's a moment, an underused strategic asset for particularly addressing those wider determinants. And that the strategy feels too high, although Rad has alluded to the fact that some of this is being addressed in today's agenda and forward, but it's almost too far from delivery. So people don't have the ownership that you might want, which then leads to weakened mutual accountability. And we see this as an opportunity to further strengthen that mutual accountability between the different partners on the board, leading to then collectively improving outcomes for the population of Plymouth. So I'm going to pause there. We're just going to sort of pause in our talking at you and give you a chance to just reflect on those comments, those contributions from Rada and from myself, those summary of those key points or messages. Is that how you see it? This is a chance for anyone to just respond and reflect. Does that feel an accurate representation that we've presented back to you? Is anything missing? So happy to take your comments. I don't know whether you want to put those back up, the actual 7. Yes, Michelle.
Thanks very much. Yeah, if I chair it and go round as I see hands up or in the room or on the board. So Michelle, if you want to go first.
Okay, thank you. I think that this is the right time, and actually making sure the Health and Wellbeing Board has its place in that governance structure. So it shows the importance of the Health and Wellbeing Board and where the direction comes from. I think there have been gaps around what's happening right across the geography of Plymouth. And what happens is organisations coalesce around each other and things start to develop and things are moving at great strides. And there's many people in this room or virtual room that have been very much part of it. I think as well, there's something about a definition of what we're talking about. If you look at integrated neighbourhoods, have we really defined what a neighbourhood is? Because a neighbourhood to a councillor will mean something completely different to what is being developed. It's making sure absolutely that primary care has a voice, but it's a voice that's true to all primary care. And don't forget, primary care isn't just GPs. So, and there is significant communication with GPs and their representatives, but it's to the side of this. So it's just making sure that the Health and Wellbeing Board are covered and are informed in the right way. And I think Steve Madden has definitely, been very much in the thick of it now. That it would be really clear that where Health and Wellbeing Board sits compared to the local care partnership, compared to the development of the integrated neighbourhood teams, to the work that's going on. So I think there's some of these statements that ring true, that you found, but I do think some of them don't, because there's an awful lot going on where perhaps you haven't picked up from everyone.
Thank you, Michelle. Right, Gary.
Thanks, mate, and thanks for that presentation. I've got one for now, and I might come in a minute. I was really interested in the section around quality of relationships, and it was just, for me, it was making me think about actually how much change locally is happening in that really senior level. So if we look at what's going on in our ICB, if we look at what's going on in our acute trust, and actually for us, so I guess I'd be really interested to hear some thoughts around what you feel is needed, if you like, to kind of maximise that as an opportunity, as opposed to looking at it in any other way, and how we kind of build some of those relationships afresh with those new individuals in a way which really helps. So I'd just be interested to hear your thoughts around that.
I've got Andy, Steve, Karen, and then Jemima. Okay, so Andy.
Thank you very much, Chair. Once an audit and governance chair, always an audit and governance chair. So I'm looking at point number one, your observations on governance. Quite surprised that you identified a slight weakness there in the relationship. In terms of resolving the perception or resolving an actual problem, how would you suggest we enhance that? Do you suggest we have a new memorandum of understanding between the various partners? Where are we coming from on this? Are you talking about documentary governance, or are we talking about just the loose arrangement?
Steve. If we take all the questions, and then we can have a good session from that. All right, Steve.
So I think just some observations from me. What has been highlighted does resonate, which I think to me feels a little bit disappointing, because as the Health and Wellbeing Board, we have been on a developmental journey for about the last 6 months, and I thought that we had resolved some of these issues, particularly around understanding what the role and responsibilities is of the board and its members. So I think there's still more work to be done there. We had recently reviewed the membership of the board, and thank you for Michelle for pointing out that yes, we recognise that primary care is missing, but what you'll also recognise this morning is both hospital representation and ICB representation is also missing. So our fundamental health partners are not in the room. But alongside that, recognising that when we talk about primary care, we do generally feel we're referring to GPs, but it isn't. It's the pharmacies, it's dental, and it's opticians. So we do need to look at how we reflect that in our membership. Consistent attendance, I think, was highlighted through that report, and I think we've conceded this morning that we don't have consistent attendance, which is a real shame. I would like to challenge that we are data driven. I just think the board has got a bit distracted by the kind of the core purpose, and that we do have data there. The Plymouth plan is our guiding star and is constantly evolving, but it does highlight the fact that we haven't necessarily been as aligned in that priority space. And as you've highlighted, having that single version of the truth and having a single vision for the priorities for the Health and Wellbeing Board is really important. I'm glad to see it on the agenda this morning. I've talked about clarification of roles of the Health and Wellbeing Board, and I think there's probably more we need to do that, because I thought we had cracked that nut in relation to why we're all here. In relation to strategy and outcomes, I think I wouldn't disagree with that. I think the Plymouth plan, which is our kind of key strategic document, is very high level, but doesn't get into the detail of what are we actually going to do as a board to drive forward the health and wellbeing agenda for the city. And I think the subsequent agenda item we've got in relation to priority setting will allow us to address that. I think a lot of this information is really helpful for today, because it will help to shape and inform the Health and Wellbeing Board going forward, particularly in relation to being data-driven and outcomes-focused, which will be the building blocks for our priorities for 26-27, which we will see more detail on at the next Health and Wellbeing Board in June. So I think that's really helpful feedback. And just to say a huge thank you to everyone that did complete the surveys or did participate in the interviews, because it does help us on our broader journey. Thank you.
Thank you. Karen?
Yeah, thanks, Steve. Just wanted to raise the point within the survey responses that it was like between 30% that came back, and just sensitive that although POP were named, which is great, I think that's probably just because of a survey response rather than a one-to-one conversation, and that might help Mandy when she was going a bit, ouch, why weren't we spoken to? Yeah, so I think perhaps a 30% response on the survey response might have affected some of these findings, and that's actually not your problem, that's our problem as to why 2/3 of us didn't. Thank you.
Jemima?
Yeah, a couple of things. I think the attendance issue is really important, and we can't, you know, I think about who should be on the board, and actually I think if you look at our priorities, I think we also have to marry those two things up. Who needs to be here to make sure that we can deliver on the priorities that we've all of us together identified. So I don't know if we need to have some kind of action chair around attendance and encouraging, because I don't know what stick we've got. Let's use a carrot. But really, you know, it's disappointing that a number of people don't regularly attend this board. So how can we be working with them or holding them to account if they don't come? So that's tricky. And also just, I think quite often in these conversations, when you talk about community representation and you talk about elected members, you talk about them separately. And I'm that annoys me, sorry, because I think we are community representatives as well as being elected members. We've been elected by our communities. So I just prefer if when you're talking about community representatives, it's the breadth, and don't talk about members and community representatives as separate. But I think we need an action around attendance, because we've got a really good, clear set of priorities that we really want to deliver on, and we need everybody in the room to do that.
One of those things that I realise that if you look at what's going to be put onto the Health and Wellbeing Board, I think quarterly meetings are not sufficient. I think we're probably going to have to look at the how many meetings we have and how far apart, because as you say, you know, if we've got things that we need to be doing, we can't wait 12 weeks until we come back for something like that. So I think that is one of those things that we need to think about. Being sort of minded that our remit is done by the constitution of this council, what we are going to have to do is to look at, if we're going to increase the membership, etc., it's going to have to go through the correct channels to make sure that we do that. And so that will be quite interesting. I mean, you've always got people that are quite nerdy and want to help on things like that, so that should be good. But I agree with you. It's the fact that we have these empty seats around the table, and as far as I know, behind David Haley, nobody else has apologised for not being here. It does constrict how you can get everybody engaged. So I think that's also going to have to be something about the letter that goes out to organisations to say what level of representation we want from them and their commitment to doing it. There are, you know, Karen's been here regularly, Rob's been here regularly, you know, so we have that commitment from that. And officers, again, I'm not faulting them, but the ICB isn't represented and stuff like that. So I think there's going to have to be a wordsmith that works the letter that goes out for that commitment. And I think it's got to be a response to that letter is then put in the files so we know who to say, you ain't be coming. I mean, Tony, if it's not in person, he's online, and that's brilliant because we do need Health Watch. Whilst it's still in going, we need their input because they are hearing some of the hard stories that come out that we haven't done our job. So I think it's really interesting, isn't it? That I think this was stressful doing it, but it was needed. So is it Tony that's got his hand up there? Sorry, I can't. It's Michelle, yeah. And then I do want to come to Rob and Tony for comments, because obviously if they were in the room it would be easier. But we'll start with Michelle, and then I'll go to Tony, and then to Rob.
In support of you, Mary, what I was trying to chair, sorry. What I was thinking that it's actually restating the importance of a health and wellbeing board, and particularly in these changing times, and the governance, that it is so important that the right level of membership from each organisation is represented. And we will never get a day right. So Thursdays are awful for me, but it depends on the frequency and how everyone manages to get there. But it's much easier being able to do the virtual bit too.
I think one of those things that I would like us to think about is if we have a named person and a named substitute, so that the main person can make sure the substitute has seen the minutes and knows what we're doing. I mean, they're even welcome to come and sit around the outside of the room and listen, but I think that might be something that might help. All right, Tony.
Can find the mouse and the microphone then. Thanks, Chair. I'd like to support you in your comment about more frequency of meetings, and whilst that may provide a challenge moving forward, I think there's just so much going on with the 10-year plan and the setup of integrated neighbourhoods that needs that sort of sharper focus and a more frequent focus. We've identified at a previous meeting some of the challenges around that we potentially become siloed, or we end up with duplication, or we end up with a postcode lottery. And I think with all the different elements that are involved with setting up those neighbourhoods, it's really got to be taken by this board to drive everything forward. So I would definitely support that. In terms of patient experience, I guess whilst the demise of Healthwatch is just over 12 months away as an organisation and a statutory independent body, the actual functions of Healthwatch will transfer, so that patient voice should still be available. But I guess Healthwatch is entering a transition period over that, and it'll be interesting for my sort of successors within the Healthwatch organisation to see how that drives and keep the board up to date with where things are going, because I think the messaging from central government hasn't been brilliant to everyone on it at the moment, and there's still a lot of unknowns around it.
Thank you, Tony. And I think that's what's good with the team, that they can at least take that back to the Department of Health and make sure that they're understanding of our concerns, because we certainly have been concerned that Healthwatch will be going, because you've been such a very, very useful contributor, and your reports have always been excellent. And I think that's what I really think they need to figure out what they're going to do instead. Whether it's son of or daughter of Healthwatch, I'm not too sure, but I have a concern about organisations looking at their own development and producing things, because I think that's when you miss bits and pieces, don't you? And these are often little bits and pieces are important to the public, and that trust is there with Healthwatch. Rob?
Thanks, Mary. I think it's important to remember that this is a snapshot in time, which is also from feedback that was probably secured several weeks ago or a month ago, and we're in the middle of a journey, and things have moved on significantly since I had my conversation with Ash. So I think that's important to recognise. I've been reflecting a lot on engagement with how we can get greater dissemination and understanding of the work of the board and of the key priorities, and how we can make sure we can articulate, particularly from the voluntary sector, that wider engagement, and thinking about my own responsibility here. In my discussions with Ash, we talked about there is no formal voluntary sector infrastructure, large infrastructure organisation like there is in cities. We've got POP, who an amazing organisation, and a non-traditional voluntary sector infrastructure support, I think is the best way I'd describe POP. We've got a vital role. And I think there'd probably be huge pushback against some form of traditional formalised voluntary sector body to provide a conduit to the sector. But for those of us who do sit on the board, I think we need to challenge our ability to and our role to make sure we take the conversations out of this and be able to take them into the wider voluntary and community sector, and make sure we can truly amplify people's concerns, hopes, fears, ambitions, and really to take that frontline voice and bring that, and that lived experience voice, and somehow bring that back into this forum to really act as a key learning opportunity. So there's something about the cyclical nature of how change is affecting people on the ground floor, and how we can more immediately bring that back into the into this group to inform live decision making. So they're just reflections for me at present, and this links into the development of integrated neighbourhood teams and the role of the LCP delivery board. And so I think it's common across all these different forums.
Yeah, thanks, Rob. I think that's what it's. There's always going to be, who do you ask to be on the board, and you know who unfortunately gets excluded, isn't it? And so it is going to be difficult. But I mean, Karen's here from POP, and I think that is great, and you complement each other really, don't you, with the functions of the improving lives, etc. So I do think it's, how do we make sure that we get that representation, and how are we sure that you two or your organisations are getting the concerns coming in, that we can then listen and hear what you're saying when we have meetings. Thank you. Gary.
Thanks, Mary. And actually, my comment was one that I can just build on now. Rob's quite nicely described some of it, but I think there was a point for me here around when I look at the governance, and we had the conversation around data, I look at that voice of lived experience and voluntary sector and wonder whether our governance is strong enough in describing how those voices from the ground arrive in through our governance in places like this, in an LCP and in those strategic bodies, so that whatever group is then representing, there's a strong base of information that they can have to represent. Because if not, I think my experience in some places is there are people invited to groups who will do the best job of representing their perspective, but it's not that really rich information of ground up. And for me, it feels fundamental in what we're trying to do. And I just noted for our colleagues in their presentation, when we talk about governance, we're talking about those big organisations. And for me, it's how do we spread that into all those other things and really structure it in a way which delivers those voices really powerfully for us.
For me, the good thing about both POP and Improving Lives is they both send out newsletters on a regular basis. And I think there's got to be something about, we agree what the comms is going to be when something, and then that can be added in. And I think that might be a way. But I mean, we all have to remember, we are part of the community in our normal lives, so we are hearing things and can bring things like that in. So I think it is a case of looking at how this board runs and how it should be constituted, so that we get the best of all worlds. Karen.
Yeah, I think there's something like within the systemic nature of this. I really picked up on what Jemima was saying, that actually elected members are absolutely part of the community and are, you know, at many events, attending many things. I remember once when you said I met a group of young AA members, and really they should be, you know, could we get them in here to report? So I feel like we would very much like to move forward from a kind of environment where things are like slightly siloed, like kept slightly separate. I think that's just some maybe traditional ways of doing this work that we're kind of moving into a new season about. But it feels really important that we, like when we talk about community, we start to think about what that means and how that voice is, because I mean, Rob and I are great, but it would be absolutely impossible for us to say this is what the community think, because that's just nonsensible, really. Yes, so it's like, how do we get a multitude of voices into the room, and then how do we disseminate that so people feel that they are engaged with, but also how we can make good collective decisions together with a wider like environment.
I think that's what we need to think about. Now, I've been reminded we've got more questions to ask. We've only done one so far, and we've technically only got about 5 minutes left. So, next question, please.
Yeah, I'm just reflecting, Rada, that was a very, very rich feedback from everybody, and perhaps rather than ask the questions, perhaps I was just thinking I might reflect a couple of thoughts back and just get some final comments from people in the room, if that's possible. It does seem to me from everything that people have said that there's a real recognition among everybody here that this is a new role for the board on top of the role you're doing already, but you're already on that journey. You're making steps in that direction, and that's there's a sort of a keenness to do better, and I think that does involve, as people have said, breaking down some of the silos, more mutual accountability, but crucially having the right people in membership, and the gaps that are there. You've articulated those very clearly among you, and that means to do the new job, to take on the new role, those seats need to be filled, and they need to be filled with a named person or a named substitute, and people being kind of personally committed to taking part. And I think that was a very clear message from you as you're discussing between yourselves, and the right people with the right commitment and the right level of people in there. And that includes that really challenging point at the end about how you capture multiple voices from the community and from people with lived experience and from patients, and recognising the various views there. So I thought that was very clearly articulated. That being data-driven and outcome-focused, and then being able to decide things and communicate them. I think that's come out from me about the communication challenge for you, both with the communities you all represent, the constituencies you come from, but to each other, to almost mutually reinforce the work that is going on and the success you're having, and where the gaps are and where they might be filled. And you've mentioned a number of things about ways of working, how often you meet, whether some of those meetings might be more developmental in their nature, with a wider group of people being involved, so have sort of workshop style meetings as opposed to meetings, as it were, as part of the way of working might be explored, and tracking your progress. I thought, I think it was a point others have made, Gary was one, but where we're going, how we're doing, telling each other what's going on, so celebrating that success, but then saying, no, but we're not done so well on this. And I thought the opportunity, if you do have changes of senior leadership inside the NHS, or whatever part of that is an opportunity to take on this new culture that you're describing, this new role, and bring those people into that and to share that job and that leadership, so that they see that as part of their role. And to be honest, I think a change of personnel is very much an opportunity for accelerating the process and the journey that you're on, and you can take that as an opportunity. I'm aware that time's out. I've just tried to sort of feedback a few thoughts that I thought we've recorded it. We'll capture a lot more, but I thought that was a really, really rich and helpful conversation. So thank you.
Thank you. And sort of coming back to Michelle about Thursdays being bad for her, I think if we do one of those doodle polls or whatever they call them, and find out if we can get a consensus, or maybe if we're going to go to additional meetings, we could have them as private ones rather than a public meeting, and maybe we have them on a different day to the meetings like we're in today. So I think there's lots of scope, but obviously I appreciate that everybody's diary is very busy. So we need to take that on board. Now, before I close this, anybody else got anything to say? I mean, Elliot, I would quite be interested in, from a governance point of view, as in, we know that the diary's been printed for this next civic year. Will we cause too much mayhem by saying we want 6 additional meetings in the year?
Through you, Chair. It's Chair's prerogative as to when meeting dates and timings are. We try to avoid too much move, but they are sometimes necessary. So I suggest we pick up in the next year, do a survey of members and then arrange based on that.
Great, I've got power, hooray! Can I just say a big thank you to the team? I know it's been hard work, and I know we probably all haven't engaged as well as we could have done with you. And I mean, like Michelle has not been interviewed, and obviously she's an essential part of this team here. And certainly we need to figure out how we get somebody from primary care in its broadest sense. As you say, it's not just GPs, there's a whole lot of other teamwork within those. So I think that's going to be one of our headaches for the next few weeks. So thank you very much indeed. And presumably once the instructions have been released from the Department of Health about how these neighbourhood things are going to go, we're going to have our homework to do then on that, and make sure that we've got big elbows and get to the front of the queue as to how we organise this. So thank you for your help. It's been worthwhile, even if it has been a bit traumatic to us. So thank you. Ashley, do you want to say something before you all disappear?
Thank you very much.
Thank you, team. We'll let you go now, and we'll carry on with the meeting. Bye. Right. Okay. So lots of homework there, folks. Right. I want to now invite Teresa to come up and get grilled on the Health and Wellbeing Board's priorities for 26-27.
Well, hopefully I won't be grilled because this group decided the priorities. So you've got a paper. I've not prepared an additional presentation because I feel like we've already talked about these topics, but following our recent workshop where we talked about 4 priorities in that workshop in a bit more detail, and then the group added 2 additional topics that they felt were important priorities. So falls and frailty, potentially to be renamed at Gary's request, and also culture for health. So effectively the document that you have is I've put a little bit more detail onto the falls and frailty and culture for health elements, but the proposal is that the board agrees those 6 priorities that we have now. So that's oral health, including dental health, cardiovascular disease prevention, Plymouth as a marmot city, integrated neighbourhood teams, which we've just been talking about, and then the falls and frailty prevention and culture for health. So yeah, just seeking the board's agreement that we're happy with those 6 priorities for the coming year. I'm happy to take any questions if anyone wanted to raise anything further.
Can I just say the looking at cardiovascular disease is quite an interesting one. A friend, her husband had decided to go to the well-man check that they were doing in his place of work. They took his blood pressure. I think he probably broke the machine, it was so high. And of course that then made him go to the GP. So, and that was one of the Live Well teams that were out in a place of work. So Michelle, great. That they're obviously picking up things that people don't think to go to the doctor to have regular checks, whereas he had taken the time to utilise what was on offer, and he's obviously going to go through a lifestyle change with what happened. So brilliant news that was. Anybody got any further comments? Right, Rob.
I just check with, thank you, Mary. I just check with Teresa. Did you say just for the next year? Or are we talking much longer term than that in terms of these priorities? And also, not to completely reopen the debate again, but I suppose we never heard about other considerations for other potential health priorities. So we had the presentations, and they all felt very clear reasons as to, rationale and evidence why we should adopt them as priorities. But I suppose in taking the discussion back into my own organisation, people are asking, well, what about mental health, or what about other conditions? And I suppose it's like, how do we narrow it down to that subset? What were the other considerations about other areas that we could potentially concentrate on? And yeah, how long are they priorities for before they get reviewed again?
Michelle? Michelle, do you want to come in now, just in case it's something that we need
Yeah,
to answer?
so there's two things. Firstly, on your comment, the Live Well staff, but it's actually part of our public health staff. So actually, that's a joint council and Live Well action for the guy who had his blood pressure and etc. And also the healthy lifestyle afterwards is our joint venture. From an integrated neighbourhood team, Rob, mental health will definitely be part of that. And I would also say the other bit, children, young people, definitely part of that. So I think there's a danger that we look at integrated neighbourhood teams as a frailty, elderly type thing, but it's not. It's about our communities in those neighbourhoods, that from health and well-being and prevention and all of that. But it's how we would work with schools, if you look at working with schools, children, young people, mental health in schools, that's all part of what would happen in a neighbourhood. So it's, although it's not spelt out and as a mental health condition, I think the mental health element and children, young people will be picked up via INTs.
Thank you.
That would be my response.
Yeah. Do you want to come in, Teresa?
Yes, thank you. Completely agree, Michelle. And I think actually it's for communities to determine their priorities on that kind of more local footprint. So I guess this is us just giving some overarching direction. But I think in terms of the timeframes, we also need to think about the refresh of the Plymouth plan that's going to be going on throughout the course of this year. So I think first of all, there's opportunity to bring new priorities into that refresh. So something that might need to be looked at in a longer term sense, or might need to be our priority kind of next year or in coming years. So I think that's probably the opportunity to consider other priorities. I think in some respects we'd focused on things where we know there's already a bit of energy, there's already a bit of focus within kind of board members' activities, amongst colleagues at the hospital or in primary care, amongst VCSE organisations. But I think it's for us to kind of bring forward additional priorities if we wish to, and kind of give those good consideration and work out, do those come into our this year? Do they come into our Plymouth plan longer term look? Or do we put them on the list for next year? Because I think that there's huge numbers of priorities that we could consider, notwithstanding that most of them will be looked at on a more local footprint as part of that INT work, as Michelle has said.
Thanks, Steve.
Thank you, Chair. So I think just to echo the sentiments of both Michelle and Teresa in this space, the devil's in the details now, and I think what we're showing you this morning is the outline of those kind of overarching strategic priorities, where there will be more detail that follows at the next Health and Wellbeing Board. We did have this conversation when we had the workshop, so the falls and frailty element and the culture for health are two additional priorities beyond what we initially proposed. So we have listened to board members in that space. And then just to expand a little bit on what Teresa was saying is the Plymouth plan, which was originally introduced in 2014, is currently being reviewed so that it will then go to 2050. So we have proposed these as the initial focus for 26, 27, because as Teresa said, there's a lot of energy already in this space at the moment. But the board members and wider colleagues will be engaged with to talk about what are the broader priorities that take Plymouth Health and Wellbeing to 2050. So there will be an opportunity to have that broader conversation as well. I think recognising on the earlier conversation in relation to just giving the board some direction, and it brings together some oversight in relation to work that's already happening as well, I think is also really key. Thank you.
Jemima.
Thank you. Yeah, I mean, priorities are always going to be a bit of a bun fight, aren't they? And somebody will always say, well, you haven't looked at this and you haven't looked at that. But I just want to say that I'm really pleased at culture being on there, and how you've expanded it and how you've described how we're going to look at it I think is excellent. And actually, I think, there aren't many places looking at culture through a health and wellbeing lens. So actually, hopefully we might be able to do some stuff that's quite innovative and groundbreaking that we'll be able to share with other local authorities or other organisations across the country, hopefully. So I really welcome that being on there, and how you've expanded it into, rather than me just saying, I really want this here, you've turned it into something meaningful that we can really, really look at. So I'm looking forward to, particularly to that part of our agendas. Thank you.
Excellent. And, we accept the premise that the National Health Service was put there for cradle to grave, isn't it? So we do need to make sure that it's all encompassing, certainly. Gary.
Thanks, Councillor Aspinall. Again, supportive of the priorities, but listening to that conversation, and I think earlier there was, Rob, you talked a bit about when you're going back into your work and engaging and communicating with people. I just wonder whether there's something in our comms message which is about, these are the strategic priorities, but there's a lot of other things. That doesn't mean there isn't anything else happening, mental health. So, it's kind of making sure that people are aware all these other things are still going on and they can still be important, but these are the real strategic areas of focus that the Wellbeing Board wants for that period. So I think there's a way we communicate that which can help people understand. And I just want to reconnect to my governance point about bottom up, because I think this also links to how those people tell us what the things are that they feel are important, so that we are seen in the reprioritisation decisions of the future, that feeds into them in a really nicely structured way. So that kind of closes the loop, doesn't it, a little bit?
Thank you. David?
Thank you. So again, supportive of the priorities, and I think they represent the conversation that was had really well, and I think the two additional priorities are helpful. Just two additional points in terms of the point around that's been made a couple of times around the mental health and emotional health of the population. I just wonder how we find a way of representing that in here, because we may have a large percentage of the population, Plymouth population, who do access and have their needs met through those services, and they may feel, as written at the moment, that isn't represented anywhere through our strategic priorities going forward. So I wondered if the culture for health, for example, is a place where we may be able to put some of that in relation to that. But just a thought about how we do represent that element of health, and it may be through priorities that are additional to this or wherever that sits, but I think we just need to be aware of the people that access those services and how we're seen to be representing them. And the second point, I would just say again, once in this meeting, because I think I said it 3 times last time, as we develop these up, Teresa, perhaps we could have a conversation and work with our teams around the children's elements to that. I can see that they've been sort of fleshed out a bit more within the dentistry, but I think there were some things, for example, in cardiovascular that we said we could commit to in doing with schools and children and young people. So we can work that up, I think, together, ready for the detailed delivery plan.
Thank you. I just wonder whether you might have, let's say we have the topic of cardiovascular disease prevention. It may well be that we could put a couple of bullet points underneath to say what it might include, or whether that is more counterproductive, I don't know, but we'll need to think about, as you say, how we make sure that children are there, that nobody's going to miss that fact. Andy, and then Karen.
Thank you, Chair. Full support of the 6 priority points, and thank you for all your hard work with this. Certainly point 1, oral health, which has been a major issue, and it straddles so many committees on this council, including dental health task force, which Mary and I are involved in with Jemima, and also Jemima's campaign for the children's teeth. It's such an important element, and scrutiny, this was brought up yesterday at health scrutiny, and I think what we're trying to do is come up with a better action plan for getting dentists to retain themselves in Plymouth and provide services. Can we have a bit of an overlap with the other committees involved in oral health, so that I so press it is a priority, and perhaps a degree of collaboration between the various committees to try and drive this home. Thank you.
Karen.
Yeah, just to clarify the previous part, I'm sure the children and young people healthy weight work fits very well into cardiovascular priorities. So I think there's a very direct link there.
I think when the next item is about the health determinants research collaboration, and there may well be a place for them to help with some of the bits and pieces that we want to see done. So to me, it's quite an exciting thing. Yeah. Sorry, my phone's going off in my ear. Right, let's leave that. Sorry. I've pressed something now on my phone and it started my book that I've got on here.
It's all very clever. Too complex for me.
Is it a good one?
It's the the Richard whatever Osmond that writes all those books, and I've got it on my. I should have brought this in with me, should I, today? Sorry, folks. Right. Right. I think I've stopped. Thank you. Sorry. Right. Okay. So where were we? Karen, thank you for that. Anybody else got hands up that I can see? Tony, do you want to bring anything in? Michelle, you're all right? You're happy? Yeah.
Just from me, Mary, I support the recommendations.
Lovely. Thank you. Okay. Anybody want to say anything before we close the item?
So I guess we're just confirming that they're approved, and then what I'll do is I'll work on delivery plan for subsequent health and wellbeing board.
Thanks.
Thank you.
So we have recommendations. We recommend 6 priorities for the Health and Wellbeing Board over the 26-27 period. That's oral health, including dental health. Secondly, cardiovascular disease prevention. Thirdly, Plymouth as a Marmot city. Fourth, integrated neighbourhood teams. Fifth, falls and frailty prevention. 6, culture for health. And that's not in an order of what's senior, if you see what I mean. It's just a list. So can I have your agreement? Can you give me, yeah, everybody happy? Excellent. Thank you very much indeed. So that's sorted on that one. So thank you, Teresa, for your input. It's really been helpful, and as usual, we value that. So the next team to come up is, and they're a bit early. Good grief! Can we have this down as a record? We're actually early. So Ruth and Gary, do you want to come?
Okay, Lovely. Thanks very much for the invitation to come back and talk to you about the HDRC. I think this is our annual update. So we've enclosed a brief paper, but just to recap, the Plymouth Health Determinant Research Collaborative is fully funded by the National Institute of Health Research. Probably about 5 years ago, the National Institute for Health Research recognised that the wider determinants of health were both incredibly important to the health that they were generally researching, and also were not contained within the ability of the NHS really to impact. And therefore, they started to widen their view and think about working with local authorities to make sure that the evidence on the wider determinants of health and how that impacts health was both the evidence base was both used in councils, but also the work that councils are doing, where it's innovative or novel, was evaluated and then was shared amongst other local authorities, so that the learning could be shared and understood and embedded in wider areas. And this is something that is obviously very important, but it gets quite complicated. And the reason why it's complicated, I think you could say, is that some of the research the NIHR are used to doing is more around medication or surgery, things like that. So there's a much easier pathway there. You give a group of people a tablet, you give a group of people a placebo, and you see what the difference is. Obviously, it gets a lot more complicated if you're talking about things that might be on a wider community basis. So, you renovate a park, or you have a new school, or you see improvements in housing. The evidence can be a little harder to discern because people's lives are complicated. So we put in a bid, working with the University of Plymouth, particularly to do two things: to develop the skills and culture within the council, to ensure that a learning approach informs decision making, and also to look at producing that knowledge and widening its use so that that could be shared locally and of value nationally. And we had a particular element working with the university around coastal communities, as that's one of their specialist areas. So we developed the bid, we were successful in that, and we're now been running for about 3.5 years. Did take a little while to get up and running. We were one of the first in the country to be awarded a HDRC. And what we will do is, Gary in a minute will give you a couple of highlights of some of the work from this last year. I will also just mention that this was a 5-year bid, and so obviously we've got about 18 months to go. We have had positive noises from the NIHR that they do want to commission us to continue for longer. So rather than doing a full commissioning process where you might have to apply for a research grant again, it looks as if they might want to extend our current arrangements, but it is a little bit up in the air at the moment. So we will let you know when we have certainty. At the moment, we only have sort of verbal arrangements and verbal signs of what might happen. So, but we obviously hope that we'll be able to continue this arrangement. So I'm going to hand over to Gary to talk a little bit more.
Can everybody hear me? So I'm just going to pick out a few things. So obviously we are assessed annually by the NHR, and we've been assessed as performing well, and they've actually selected us as part of the 20 years of NIHR celebration. They've selected us as an impact case study. So they will be featured in all of their events around the country celebrating the last 20 years of NIHR. So that's kind of nice for us as a council to have. A couple of things. We are doing stuff under the highlighted examples around council priorities. A couple of our projects are demonstrating how different ways of doing things can save money. So particularly the Creative Solutions Forum and the work around trusted professionals with youth in transition between childhood and adulthood. But some of the things we're particularly pleased with is so all HDRCs, because of the financial climate, have struggled to fulfil the part of the agenda around recruiting council staff, training them, backfilling their posts, because everybody's kind of on their bare bones. So we're really pleased that we now have fully funded work from the Children's Directorate to undertake a PhD, researching high-cost placements for looked after children. So that's a great thing. A couple of commissioning staff that we are paying to go onto the First Steps into Research programme. So that will help them with their evidence-based commissioning. We've also funded an occupational therapist who's actually from Livewell to do an MSc in substance misuse work. She works exclusively in the complex needs area. And also Peter Kerslake is our seconded HROD advisor. And he's leading a plan to train all 300 council middle managers in kind of basic research understanding and research skills. So that's a really kind of a big win for us, particularly in comparison to how some of the other HDRCs are going. The other thing I'd like to mention is the sub website. We're so on the council website. If you search HDRC, you'll see our newly recruited Comms and Dissemination Officer, Kirsty Mars, has done an amazing job with lots of little kind of vignettes about some of our projects. We have more than 50 projects across the city, most in the council, but a significant number in the VCSC, and if you think of it as a Venn diagram involving health as well. So it's a really good thing. One of the things I would highlight is one of our researchers in residence, Rebecca Carter-Dillon, successfully bid for pump priming funding around getting people with health and other difficulties into work. Getting people into work is one of the best things you can do for their health. That's going really well, and we are hopeful that we will get a much more substantial bid later in 2026, building on that work. But other than that, I'll shut up now and leave you to ask questions.
Gary, thank you. I've seen some of those little vignettes from the team, and they're brilliant. And I think we need to think about how do we make sure all the councillors in particular know what's happening. And I think you'd be hard pressed not to find some part of their interest that you've got the HDRC stuff going on. So I think, how do we get that going? It's all very well for cabinet members to see that, but it needs to be more, because I think it's brilliant what's going on there. Jemima, did you want to say something?
I'm obviously particularly interested with the children's social care portfolio around the research around placements, and I'm not sure of the timeline of when we might know what that kind of research is looking like and how we can use it. And again, I wonder, I don't know if this is something that's happening in other places. I mean, everything you talk about, Gary and Ruth, you just think this is so innovative, and it's such an interesting approach to, particularly from a council point of view, some really challenging issues and really wicked issues in the council. But I am obviously particularly interested around the children's placements work. So could you just describe a bit more about that?
Yeah, so obviously Letitia's just started. It's 3 years, fully funded, full time. So it'll be 3 years before she reports. But part of the first year is largely literature reviews, literature searches, that she will inevitably uncover published research, which will be implementable immediately. And so that's one of the things we've talked to her about. As you're doing those and you come across evidence, let us know and we can implement it. We don't have to wait until the end of your PhD. We have already done, like I say, some of the work around trusted professionals, which is implementable and could save money because it reduces so much duplication. It's a kind of productivity gain. Reducing 4 or 5 workers to 1 single worker is a kind of significant gain. So, there are people in the University of Plymouth that we can call upon to investigate specific aspects of the kind of problems facing children's social care all over the country.
I think from the sound of it, I think you're saying that it would be good for us, to the relevant people, to have some extra knowledge on that, and I think that's what we need to sort. David?
Things that you've prompted me to think about, the Reconnect programme. So when you're talking about the piece of research about helping people access employment, there may be something we can do to strengthen that across that Reconnect programme. So there's significant resource and capacity there now for a limited period of time that may be helpful.
Yeah.
And the second is picking up on Councillor Lang's point in relation to, it'd be really good to link Lettice into and be a member of our Plymouth Family Homes Strategic Board, because I think we could get more, real value out of that, both learning from the research as it's coming through, but also providing opportunities for her to tap into our transformation programme and what we're doing across the city. So I'll take an action to invite her if that's okay.
One of the other things we've done is allocate an associate professor, Ollie Beer, is an associate professor of social work, to the Children's Social Care Directorate. So he's supervising Lettice. He's an ex-social worker himself, and he's already liaising with children's social care social workers to look at implementing already published research into their practice.
So I'll make sure that I push that up to a more strategic level of which is clearly operating.
Thank you. Thank you.
I think the one on transitions as well would be really useful. I mean, just to point out that scrutiny, I think, are looking at that in the next year, aren't they, for that? So that would be useful to have some input as much as you can for that as well. Anybody else? Karen?
So yeah, brilliant work, obviously. Very pleased to hear Kirsty spoken about. That's amazing. The reports on the website are really great. I was wondering about the HDRC's influence or ability to support senior leaders and people within the cabinet and within the the way that we organise and govern. And I guess I'm specifically in my head thinking about AI and thinking about how that's being kind of implemented throughout the council, but also what are we learning about that? How's that affecting the way we work and the way we have relationships and that kind of thing? And I don't know if that's just a random thought that I've had or that's useful.
No, thank you for that. I was going to say that two things, I guess. One is that we are doing quite a lot of work on AI as a council as part of our Enable programme, so that is being looked at. There are some links with the university, but it's not an area that we've currently got strong academic support around that. So we would probably, if there was a need for something like that, we'd be very happy to look for partners elsewhere that might be able to, or elsewhere in the university possibly, that might be able to strengthen that if necessary. But yeah, we're absolutely willing as a HDLC to talk to anyone about the needs that they might feel that there is to sort of try and draw in some expertise.
To clarify, is that the pathway? So if there was a department within the council that was interested, they would come to you and say, we're really interested in this, can you support us? Yeah. And is that widely known everywhere? And do you have the capacity to manage that if...
Our operating model is we only do research which is generated from the work in the council, which is the opposite of the way research is usually done. Usually an academic has an idea and they look for a partner they need, whose data they need. Our approach is we only do stuff that's generated from council priorities and council staff to try and kind of rebalance that. So absolutely, if it was a council priority, we would prioritise it. Obviously, we have far more demand than we're able to cope with, which is why it's so important that we develop home capacity for research, within council departments. So we also have to go through a prioritisation process within the HDRC. But the thing that informs that is council priorities. They take priority. That's an awful lot of use of the word priority.
Thank you for that. I do think we've got to think of a way how all councillors get to know that this is going on, because your research will make quite a difference to how we practice things and do things, isn't it? So I think I've given up trying to get little films at council meetings because there always seems to be something that goes wrong with the IT. But we do need to think about this, and so if we could get thinking caps on. Steve, did you want to go in?
Gary.
No. Gary? Right.
Yeah, thanks. I just want just picking up on the point of priorities. I guess one, it's always nice, and I saw in the national work you're doing, creative solutions is one of the really big successes. It's great that we keep sharing that. Through Casey review, I was hearing her say some things that might be interesting in terms of connecting. But also the test, learn and grow work through Whitley, I think is really fundamental in terms of one, priorities for this board, but neighbourhoods and our partners. So I think what you can see is that stream of work, some which have delivered and some which we know will deliver, some of that really important learning for us around what neighbourhoods should be like, what they need to do and what will work locally. So I think I just wanted to kind of...
And if I may, that's an example of where we've influenced the Cabinet Office, and then the Cabinet Office have worked with us with that programme. So Gary's expertise now is you've been providing quite a lot of support into the Cabinet Office on things like human learning systems and complexity. So it's nice that it did go round in the circle, meaning that we were then involved with that programme that the Cabinet Office were funding. So yeah, or supporting, I should say.
Yeah. Sorry.
I should mention we have a YouTube channel as well.
Well, that probably needs to, that would solve my problem about how do we get everybody to know, wouldn't it?
Yeah.
I think with the, the messages that come out once a week from the comms team, it might be useful to put a little thing on there and then the link to that.
Yeah, we can do that.
Yeah, great.
Yeah.
That was great.
Unfortunately, the first thing we put on was a very amateurish interview.
What better since then?
But we're much better now. Yeah. Unfortunately, I can't delete that one.
Well, I think you're brilliant because Facebook caused me problems, I tell you. Right, anybody else want to say anything? No? Right. Thank you, team, for coming and talking with us. And certainly we will note the content of the report, which is mainly for information, as we know, but we'll be aware that the council has maybe been going to be given some extra funding, which will be brilliant if that happens. And as I say, well done to you and the teams. I think it's really good piece of work that will benefit lots of other councils, etc., not just ours. So thank you for that. Right, well, we're still ahead of ourselves, folks. Kamal, the floor is now yours. Come on up to the table. Good morning.
Morning. Still morning. Yes, so thank you, Chair. So I'm here to present the annual update on suicide prevention in Plymouth. I've got a presentation that kind of goes through the kind of briefing and documents that I've shared as a way to guide that. So I'll share that now.
Can I just say, if anybody feels they can't go through this without getting too upset, please just leave the room if you need to. All right. So thank you, Kamal.
Thank you, Chair. Brilliant. So that's presenting for everyone, I believe. So, so I'm going to talk today about a background about suicide prevention, I'm going to give an overview of the local suicide data in Plymouth, talk about the registration delays from coroners in terms of how and the impact that has on the official data that we have, and give you some key information on suicide prevention, talk about the One Devon Suicide Prevention Strategic Plan, and then give you an overview of key activities from this last year and resources available to support suicide prevention. So as the chair just said, please do look after yourself. Everyone is affected in different ways, and so if you need to take time, please do. And there's a link to an overview of support services available in Plymouth there. So in terms of background, suicide is the act or instance of intentionally killing oneself, and that's only determined by a coroner after an inquest. Throughout my presentation and talk, I do talk about data and numbers in terms of suicide, but just always conscious that that does relate to real people, and the impact that has on everyone around them. And we know that that impact can be kind of quite severe, long-lasting, and devastating for the family, but also the friends and community around them. Further background. So the causes of suicide are complex and individual, but there's very rarely a single cause. And the risk factors for suicide often reflect the wider inequalities and economic factors in our society. We know that the impact is most deeply felt at a personal level, but there is also a significant cost to society from that as well. And the next bit is talking about why suicide prevention is such a population level impact, has such a population level approach, is because 70% of people who die by suicide are not known to mental health services in the year before they die, which is why we have to, it's not a mental health services thing. This is a whole population thing, and we know that suicide can be preventable, and we can learn from the suicides that we see in order to inform that preventative approach. So looking at the data, and we can see in Plymouth that the suicide official ONS data, which is based on coroner registrations, because that's the only way you can determine whether a death is a suicide or not, has shown it is decreasing in Plymouth quite significantly over time, but that kind of hides the overall picture. So that kind of data shows that for females in the red line and males in the blue line, and then a whole population in the green line, and then the solid lines are Plymouth and the dashed lines are England. So I'll just give that a moment. So you can see that we know that the suicide rate of men is higher than women at a ratio about 3 to 1, and in Plymouth that mirrors national picture. We also know that the suicide rate in England is going up gradually, but the data showing it's reducing in Plymouth. However, we have had quite significant delays in our registration through the coroner's service, and that has meant that less deaths are being registered, which means that the stats are skewed to downwards. So it's very difficult to determine the true rate of suicide in Plymouth. We know, looking at the real-time data, the data we get from the police, which doesn't confirm whether a death is suicide or not, because that needs an inquest, that the rates in Plymouth are relatively stable over this time, not going down, but it's not, it's difficult to make those estimations clearly because we can't determine whether a death is suicide. So in terms of the coroner data, yeah, I've given that background. You can see here that this presents the median time from the date of death to the date of registration. For the top graph is showing that for deaths registered for suicide each year in England, Devon, Plymouth and Torbay. Just put our geographical neighbours there for comparison. So as you can see, the median date delay for Plymouth and Torbay has risen really significantly in the last 4-5 years since the pandemic, really, where we've seen Torbay as one of the highest, or not the highest, median delay for deaths registered in 2024, and Plymouth in the top 5 in terms of delays. And as you can kind of see that corresponding impact on the suicide rate in the graph below, to see that Plymouth and Torbay's suicide rate have decreased significantly because of the increase in, it's really hard to attribute how much that is, but I think that graph is relatively clear to show that change. Torbay has previously had one of the highest suicide rates in England, and as you see now it's showing below the England average, but it's unlikely that's due to a change in it's likely that change is due to the coroner's impact. So it has a really big impact. The context here is that the coroner service moved to a whole Devon service in April 2024. And this data that we're presenting, the suicide official data, is for the year 2024. So some of that year was before the move, and then 2/3 of that year was after that move to the regional coroner service. I won't labour that point more and move on. So suicide prevention is, I sometimes say suicide prevention is everything. How our society runs is a really big part of suicide prevention. How our children are raised, how they have the best start in life, how jobs are accessible to jobs, education, green spaces, community, all of those things impact, down the line on the suicide rate. When we think about suicide prevention, so we're thinking about all of those wider population level measures. We're thinking about people who have mental health issues and how we can support them through early intervention through to crisis care. And then we're also thinking about people who are bereaved by suicide, because we know that they can be particularly impacted. And so it's important that we take that the lens of suicide prevention takes that whole approach, looking at all of those complexities of those issues. And that kind of highlights that it's not one person, not one organisation's responsibility for suicide prevention, and as much as we'd like, there's no simple measures for suicide prevention. It's everyone's business. It needs a whole system approach, which is what we are working in. I normally, whenever I talk about suicide, include a slide about language. So just for general awareness, so talking about suicide is really hard, but it is really important to talk about it, especially with someone who has suicide ideation. They could be feeling like quite a lot of guilt and internal burden about that, and if approached kind of sensitively and compassionately, it really does help that person. But often people worry about saying the wrong thing or not wanting to talk about suicide. And what I will say is that although there is some terminology that's useful for talking about suicide and terminology that isn't useful, I think if you approach a conversation with compassion and empathy, then you're unlikely to either say the wrong thing or it to be taken in the wrong way. I think that's really important, but I've just put that thing about language there. In terms of the suicide prevention, suicide bereavement service, I mentioned that people who are bereaved by suicide are at higher risk themselves, and so we do have a commission service, NHS Devon commission service, that will support anybody, adults and children affected by suicide, for as long as they need, and that can be someone affected in the last week or someone affected 30 years ago, and there are no waiting lists for that service, and the support can start really rapidly. One of the other key elements of suicide prevention is training and capacity building in the system. So, as I said, 70% of people who die by suicide aren't known to mental health services in the year before they die, but they will be known to other people, they'll be known to workforces, they'll be known to communities in other ways, in many cases. And so we have our commissioned training partner, Live Well South West, who deliver a tiered approach to their suicide prevention training, kind of looking at well-being measures, thinking about 5 ways to well-being, training in the bottom layer, and in the intermediate layer, these kind of half-day emotional resilience training or community suicide awareness training, and at the top there, that kind of advanced stage, 2 days, really specific suicide prevention training, think about mental health first aid or assist training. So that kind of gives a different offer for different people where they sit in the system. So I mentioned about the One Devon Suicide Prevention Strategic Plan. So Last year at Health and Wellbeing Board, the Plymouth, Devon and Torbay Health and Wellbeing Boards all supported the proposal to develop a One Devon suicide prevention plan to replace the individual plans that each area held. There are many reasons for that approach, which was to improve partnership working across the county. And that includes between the public health teams and mental health teams, but also other organisations that might have a wider remit. So thinking about kind of the police or the ambulance service, other kind of partners that can be more effectively engaged if we work at a wider geography as well. It also enabled more effective oversight of suicide prevention plans and maximises that capacity within the system, reducing duplication. And the accountability is still maintained through the local health and wellbeing boards for that. So in terms of developing in that plan, over the year we've done a quite extensive amount of work on this. Following last year's Health and Wellbeing Board, we mapped the existing plans across Devon, Plymouth and Torbay against the national strategy. We led a series of engagement workshops across the system with really wide, over hundreds of partners invited and attending these workshops. We developed the draft strategy, using the outputs from those workshops, and then led to further consultation on that, and that led to the plan that's in the papers for this Health and Wellbeing Board. So partners might know that the National Suicide Prevention Plan strategy is available, and our strategic plan aligns to this. So in terms of the eight different priorities, which are listed there: improving data and evidence, tailored support for priority groups, addressing risk factors, promoting online safety and media reporting, providing effective crisis support, reducing access to and means of suicide, and providing effective bereavement support. And the priority groups and the risk factors that are identified are there at the bottom as well. And that kind of highlights the breadth again of the suicide prevention approach and why the whole system is needed. So I mentioned this, but the governance of the new plan will remain through the existing suicide prevention partnerships within Devon, Plymouth and Torbay, and accountable to their respective health and wellbeing boards. The prioritisation and oversight of the group is held by the Devon ICS Suicide Prevention Oversight Group, and this enables consistent priorities across the system whilst allowing for local adaptation based on local need, because we know Plymouth is different from Torbay and Devon. There are some overarching principles in the plan. So, as I had emphasised, the localised delivery is really key, but it's informed by the national strategy. Really strong collaboration and partnership working, meaningful involvement of people with lived experience, equity and inclusion, and making sure that we are evidence informed and continuously improving. Okay, so that's the plan, and then in the final section of my presentation, I'll just talk about some of the key activities that we've undertaken in the last year. So we've reviewed the Live Well training package with our providers and introduced a new course, a half-day suicide prevention awareness course, and working towards implementing a half-day self-harm awareness course as well. We've launched a key suicide prevention toolkit, particularly aimed around people working with young people. And there's a guide for people who work with young people on suicide prevention. And then we've also worked with our colleagues in participation team and children's services to, and most importantly with young people in the city who have developed their own what's called the SOS leaflet, which is subject of suicide, which was an incredible piece of work. You probably heard me talk about it before. But it was a guide for young people, by young people, on the really difficult topic of suicide, and that came from working with the Children's Safeguarding Partnership. We've worked around looking at reviewing some of the locations in the city, thinking about some of the bridges and doing some prevention work around lighting, foliage, fences, benches, and access around some of those areas. We've been working on developing a relationship with Reach PLC, who run Plymouth Live, and this is around the reporting of suspected suicides, and we've kind of got a route, you know, in making sure that they're informed in terms of Samaritan's guidance on media reporting, and actually following a meeting with them, they organised Samaritan's training for their all of their journalists and made it a 3-line whip kind of attendance as well. So that's a really positive outcome. And we also have a route for challenge, where we see articles that we feel are not in line with the kind of Samaritan's media reporting guidance. And we've also really kind of worked on improving our general message to the community. So we've done community events and drop-ins, lots of speaking at networking events, kind of doing bespoke engagement with organisations, kind of identifying those organisations that might be working with people who are at higher risk, and making sure we're going to them, doing a talk on suicide prevention to their workforce, and also then telling them about the training packages available next. We've done social media training, so we know that obviously the media is much wider than the kind of traditional media now. So we've looked at kind of people who are, what's the word, when they are admins of groups, you know, these big kind of groups, and kind of doing training about how they might approach when there are unhelpful comments, particularly unhelpful comments on their groups. And we've done some work around wellbeing benches and plaques. I think my last 2 slides are just pictures. I'll just do that. So here's some of the benches in Plymouth that we've, so the green one is a new bench, and the bottom one is a plaque put on an existing bench. So it has a QR code, which is around mental health support, and the middle picture at the bottom there is what that QR code links to. It's a link tree, which has the various different offers of support, so the crisis support in terms of Live Well South West first response, and then there's other options in terms of texting options, Shout and Samaritans, Papyrus for young people as well. So that's all there. And then the top right is one really key bit of work is around safety planning. So we know safety planning is a really key intervention for people with suicidal thoughts. We know that risk assessment is not very helpful because risk can change as soon as you finish. So it's actually about how you understand someone's risk and actually plan with them, and that's what safety planning really comes in. And so we developed a template safety plan, which is in a leaflet, physical leaflet form. There's an online version as well, and those leaflets we've distributed. We go out to partners and give them out, and people are asking for more as well, and saying that it's helping them have those conversations with people. And the bottom picture there is from the World Suicide Prevention Day, when we held an event at the Methodist Church with really good attendance. And then finally, I mentioned earlier about the young people's work there. The 2 kind of key resources, I'd say, is the young person subject suicide guide, and then their wellbeing plan. So they made their own safety plan, which they called the wellbeing plan, which serves the same function. And then the guide for professionals is there as well. So that's it. I'll stop sharing.
Well, thank you for that. And certainly, you know, what I'm going to be asking you is to make sure that after the elections are over and done with, that we have another update on this subject for new councillors. I think it's essential that they know and can put the contacts into their phones and things like that. So, and it's always gone down well. I know it's not ever been lots of councillors there, but yeah, I think we just have to make sure we try. Gary, you want to?
Thanks, Kamal. I mean, it's a really tough subject, but also a really thought-provoking report. And there were just a couple of bits for me. And you emphasised a point, which I think is something that is really vital that we put out there. 70% of people are not those known, perhaps to those services that we would normally consider to be the most skilled and capable of working with you, which stresses the importance of wider awareness, targeted support and training, which you've talked about, and your report shows the priority groups and the common risk factors. It would be just helpful in that to understand with all that promotion, what uptake you're getting. I guess there's the groups of people you're trying to target with messages, but then there's the groups of staff who either may personally require support should an incident occur, but also are those people who might be able to see some of those signs to help. And I'm not sure what uptake you're getting and whether there's an ask or something that we might have through all of the relationships that out of the Wellbeing Board that we can foster to make sure we really drive uptake in those groups, because it feels like the 70% is the area of focus. So there was that I'm interested to hear your thoughts on. And I guess the other thing, recognising, I was listening to you intently about the coroner, and recognising that that's not going to be the position they would like to be in. But that it feels hard for us because to one, make sure our current thinking around those causes is current if we can't get the learning out of that. And I just wonder, Councillor Asman, whether there's a role in this board about trying to advocate for improvement in that space, because that does feel to be quite worrying. If you just present that chart, we will have a false and inaccurate picture of what's going on. And I'm interested in the thoughts around that, but that just feels like something that we shouldn't necessarily sit here and accept, recognising, I'm sure the coroner doesn't want to be in that place, but because presumably that's a deficit for us in terms of information and therefore being confident our plans hit the mark.
Mm-hmm.
Do you want to come in on that, Steve?
Yeah. So Gary's touched on exactly what I wanted to say, which is I just don't think this gap in time between in relation to coroners is acceptable. It has been going on for about 2 years now. It's interesting in the chart that you show, because obviously our services are delivered centrally by Devon, and Devon aren't in the same position as Plymouth or Torbay. So I'm really interested to get under the skin of that, because it seems like death by suicide in Devon gets a quicker response than if you're in Plymouth or Torbay. And associated with that, because I think there is something that I would echo Gary's sentiments, which is whether we would want to write on behalf of the Health and Wellbeing Board under the chair in relation to how we challenge that, mindful we have other challenges with the coroner, which we're also trying to deal with at this moment in time. And I suppose a question tagged onto that, Kamal, is if they do catch up with themselves, then obviously that then changes the data, because it goes back historic, doesn't it? So if the suicide happened within 23 or 24, once they've finally done the inquiry, it rejigs the data. So then that chart will effectively change. So although the chart at face value looks like it's a good news story, it isn't necessarily. But I would absolutely support what Gary's suggesting in what can the board do to try and challenge some of those issues around the delays in coroner service.
Thank you.
Right, I've got.
Can
Andy,
I
then,
just come in on? Can I come in on just?
do you want to hear what other people have got to say? That
Yeah.
might be easier then. Rob, if you come in after Andy, all right?
Thank you very much indeed. Thank you for the excellent report. You talked about working with wider partners, which I'm quite interested in. Then you talked about Samaritans and the reports you get from them. How do you go about looking at finding other wider partners? I mean, looking at the group, the priority groups, where you're trying to analyse priority groups, organisations such as the CAB would probably deal with lots of distraught people. The question really is, how, as a sort of item of your agenda, how do you look for wider partners?
So we have a Plymouth, yeah.
Let's take Rob, and then if you want to give an answer to the ones you've had, then I'll go to Karen after that. Okay.
Yes, thank you, Mary. Just building on that last point, Kamal, just wondering whether we should explore the opportunities for some structured work of intent around engagement and development and awareness raising with the wellbeing and family hubs. That's 20 hubs, probably in the region of 34,000 people a year more, plus going through. So where we've got a high volume of people going through, some of whom could potentially be very vulnerable. So maybe we could align something directly to the work that you've described about how we can align that with the wellbeing hubs more closely, if you haven't already thought about that. And the second question was, and apologies if I missed this in the presentation, was there any information given on the a connection between coroner's reports and incidents of domestic abuse, because I was just aware of another report that was, well, the reframing of domestic abuse as a public health issue, and the majority of people who disclose domestic abuse in the first instance do so to people in health services, and there's a common causal factor in subsequent review. So I just wondered whether if you've got any data and information on that.
Okay. Yeah. So if I take some of the questions in turn. So in terms of update on training, and so I haven't got the numbers with me presently, but for example, we know over 100 people in the Alliance has attended training, and quite a lot of that assist training. So for people who are working with people with drug and alcohol use, and we know there's a significant overlap, but I can get the kind of numbers from Live Well in terms of the wider reach. In terms of the coroners, I think it is really difficult because there's always a delay in the suicide data. So even now, when I come next year, I'll present the 2025 data. Obviously, the coroners, whatever the coroners have done in 25 is already done now. So in a sense, anything we do now will only affect kind of 2026 data, is the first thing to say. And secondly, I think that the difference between Plymouth and Torbay and then Devon, I showed on that graph, it comes from the previous coroner being the South Devon coroner. So I think the current service did inherit a backlog from the South Devon coroner area, which is responsible for this. And I guess to kind of be on the fair side, if you were the Devon coroner that took over in April 2024 and you had a significant backlog and you prioritised all the oldest cases because those needed to be done, that would show up as a big delay on the data that I've just presented. So I guess if they did that, it would almost perpetuate the fact that there's a delay. And I know that that's what they were aiming to do, is reduce that backlog, and they have their we've spoken to them about that, and that is one of their priorities. And then what was the other point on the coroners? I was going to say something else, but it's gone. So it's gone. And then in terms of wider partners, so actually one of the things that we are working on now, or about to start doing, is really making sure that we have mapped our partners. So we have a suicide prevention strategic partnership, or a local suicide prevention network in Plymouth that's really wide in terms of its amount of people who come to it and from different organisations. But what we want to do is properly, go out to people who aren't in those groups, who aren't attending that meeting, and kind of having those updates, having those conversations around suicide, but do work with people who are on those risk factor groups and priority groups, and bring them in so that we all go to them, or both ideally, where we go to them, talk to them about suicide prevention, why it's important, what's training offer, and come to our network. So that's the kind of key bit of work that's kind of on the agenda next. And I think wellbeing hubs and family hubs is really important. I think I think the citizens' advice is also important. So we know we work with so many different organisations in the city. I always say at our meeting, the strength is that there's so many different people from different organisations coming, but I think we can be more strategic about going out and inviting the right people as well. So that's definitely an action for me. And was that it? Have I answered?
The issue about domestic abuse correlation with
so domestic
coroners
abuse is a really important work stream, actually. So that data doesn't necessarily always come out of the coroner's review, but we do get it from other sources such as domestic abuse related death reviews, what were previously domestic homicide reviews, but as colleagues may know, that domestic homicide reviews look at deaths from domestic abuse where the partner has killed another partner, but they've changed that domestic abuse related death because actually quite a significant number of deaths, and actually the majority of deaths in Plymouth that are related to domestic abuse, and Devon in fact, are actually the death mechanism is suicide rather than homicide. So it's a really key area. It's one of the priority risk factors in the strategy, and in developing this plan, we actually is one of the workforces that we had a specific workshop for, just public health and domestic abuse colleagues, people who work in the DSV VOG space, in terms of in order to make sure that our objectives around that were key. And one of the real big challenges is that one of the key suicide prevention mechanisms is through kind of being able to talk to someone and safety planning with someone, and that's really, really key. But in someone in a domestic abuse related situation is that they don't have the autonomy sometimes to implement their safety plan. So you can write a safety plan, or even if you do get a chance to, it's a really challenging aspect, but it's absolutely a key priority of the plan, and rightly so.
Okay, Karen.
So I was thinking about people who were bereaved by suicide. I saw that there was an invitation to support for the duration. So even if there was historic bereavement by suicide, I wondered how people access that or how they know about it, because I wasn't aware that, or how they got in. And then I guess my second question, well, that one first. But my second question was around slightly around how you get more organisations involved. But I was checking out the one Devon plan, and I see Pete's Dragons in there, who are like a brilliant organisation. But I also know there are lots of other organisations that are supporting people who are bereaved by suicide. So I was wondering how they get included in, or how they can be included in this kind of work.
Yeah, thank you. So any of the talks that we do on suicide and suicide prevention will always include the reference to Pete's Dragons, and Plymouth will always talk about Jeremiah's journey as well. So and both are key members of our local partnership as well. So they always come along. They always update on their challenges. They always update on their offer to the partners. So it is, and all the links that we have as well in terms of mental health support and suicide prevention support will always include both of those organisations on there. So that's the kind of key bit about how people know about it. Is just telling as much as we can, really, and putting it on our websites.
Yeah. So I'm just wondering how somebody who has been bereaved by suicide knows that they can, at the time that's right for them, access that unlimited support. And I just wondered, is that like a GP referral? Do people have to?
I see. Yeah. So in terms of deaths that occur in since we in the last 4 or 5 years, we've had what's called a real-time suspected suicide system, which is where we work with the police, who will inform us of what they term as sudden self-inflicted deaths, which in general might be suspected suicides, or drug and alcohol related deaths, and they give us that information. But part of the police protocol on any of those deaths is to give the offer of Pete's Dragons to people who are bereaved by suicide. So that's given at the time, and that they can access that now or in the future. So since that service has been running, that's been happening, and actually there is a move. There's some work going on at the moment, and some of it's involving kind of information governance and things like that. But it's around how that offer is made on a that offer is made automatically to Pete's Dragons, so that someone in that situation can be reached to, rather than they have to always reach out. So because it's obviously been a really difficult time for them. So there's work to do there, but that offer, the suicide prevention coordinator in the police is always making sure that police officers are given that detail out. They hold the cards in terms of that bereavement service for people that they're in touch with, so that we're not waiting for. The key thing about that is we're not waiting for a death to be ruled by suicide by a coroner 2 years later, but it can be given at the time. And yes, it might not always be ruled as a suicide in 2 years' time, but this felt a much better arrangement.
Thanks, Kamal. One last question, because we were ahead of our time. We're now a couple of minutes behind it. So let's...
It's a comment regarding this being an annual report, and during the course of this year, that work that was undertaken with children and young people has been very powerful and well disseminated throughout our education and school community. And we do have a dedicated, as you reference, suicide prevention plan that we do work with all of our education colleagues on. I would just say that we can't underestimate the impact of young people that we're working with in relation to those that are attempting suicide or feeling suicidal. We have a small but significant number of young people that the services are working very intensely with in order to help and support them. So it is something which is affecting young people and quite young children as well, 12 and 13-year-olds are part of that, as well as older teenagers. So it's just worth noting that it is all age in relation to that. But that was an excellent piece of work, and young people that have used it have said how helpful it has been to them.
Thank you, David. So I've got a recommendation here. It's recommended that the Health and Wellbeing Board reviews and ratifies One Devon Suicide Prevention Strategic Plan for 26 to 31. So are you all happy? Can I have a show of hands if you are, please? Yep, great stuff. Thanks very much. Kamal, thank you. We do appreciate this, and I take on board what you're saying about the coroners, and I think I'm quite content to write something and see I know several of the cabinet had concerns when it was going to a joint thing, and unfortunately this has now come to pass. What we were worried about, so we'll do some action. Thank you. Right, now we've got the next one's about vaccination update, which those of us that were at scrutiny yesterday heard them. Yeah.
A reprise.
Okay, the floor is yours. Do you want to introduce yourselves? I mean, we know Teresa, but...
Yes, thank you. Is it presenting? Give me 2 seconds. So I'm Jake Hyams. I'm the Advanced Public Health Practitioner for Health Protection, so I'm in Teresa's team. So I'll just run you through a bit of the work we've done around improving the vaccine uptake in the city. So this first slide is just a recap of some of the stakeholders. So the vaccine landscape is quite complicated with a lot of different partner organisations. So I've tried to list some of them in this table. So everyone's got an important but slightly different role in terms of supporting vaccine uptake. The council, here we don't commission or deliver the services directly, but we are able to facilitate and support and offer insights to link services together to better support the system as a whole. So I'll start with some of the work that we have done. So in the second half of 2025, we launched the Plymouth Protects campaign, which is a multimedia campaign aimed at improving vaccine uptake across a range of vaccines, but the immediate focus was seasonal vaccines such as flu. The latest data, which was from the start of this month, showed that Plymouth's flu uptake rate was around 59%, which is above England's rate of 53%. So all the Plymouth Protect materials, which included posters and the chronicle, as you can see on the slide with Steve, they all included a URL or a QR code to the vaccine information webpage on the PCC website. And from October to February, that page attracted over 5,300 views, making it the most popular webpage on the website. We also did some specific work targeting health and social care staff, which included bespoke posters like on the slide, and education sessions which were delivered by the vaccine outreach team. And for this year, the UHP staff flu vaccine uptake was much improved from the year before, so it stood at around 57% on the latest data compared to 46 at the end of season last year, so it's a significant improvement. There have also been some changes to the childhood immunisation schedule. The most significant of these is varicella now being added to the childhood MMR vaccine. So this will now be called the MMRV and gives protection against chickenpox as well. This will be offered to children who were born on or after the 1st of January 2025 at 12 months and 18 months appointments. The advice to parents is to continue to respond to GP invites and contact their GP surgery if they have any concerns over the changes. And this advice has been cascaded to family hubs in the Early Years and Childcare Bulletin and on PCC social media channels, along with some of the resources from the UKHSA, like on the slide. Children in care. So data for children in care is collected by specialist NHS teams and then collated by corporate performance teams. This data is presented for all vaccines, and the vaccine rate was 75.5% as most recent data. It's thought that and this is above the Plymouth average rate. So it's thought that the structured health assessments and consistent contact with health services supports the delivery of vaccines and is the reason why this rate is higher. However, because it's an aggregated figure for all vaccines, it may mask lower uptake of certain individual vaccines. So that was some of the work we have done, and this will just be a couple of points on what we're doing next. So the HPV vaccine uptake in Plymouth, as you can see, is above the national rate, but we still see this disparity between uptake in boys and girls. And these figures are further nuanced as schools that are situated in areas with higher deprivation tend to have much lower uptake than the average. And although data is limited, electively home-educated children also see lower uptake rates because they're not getting that contact in the school system. So we've got some planned work to address this. So an example of that would be us working with the school-age immunisation provider to improve the information provision to schools, parents and pupils, including potentially co-producing some digital communications with the Youth Parliament. And finally, older adults, which is over 65s. So there's three main vaccines on offer. These are shingles, RSV, and pneumococcal, which is PPV. These are all year-round offerings, but they have slightly different eligibility criteria. The plan for this is to expand our existing Plymouth Protects materials to highlight the eligibility criteria, the year-round offering, and complications such as pneumonia, which are common to RSV and pneumococcal. We've already engaged partners with the Ageing Well Collective to get their feedback, mainly for locations to target to ensure maximum reach into this group. So thank you very much for listening, and yeah, I'd welcome any questions or feedback. Thank you.
Thanks very much indeed. That's really useful to know that. Just as a sideline, Senior Citizens Forum have their AGM in a few weeks' time, which is up in the council chamber. I just wonder whether it's worthwhile somebody popping along. I'll give you the contact details. That would be useful. All right. Anybody else wish to say anything? No? Gary? Anything you want to? Because I mean, obviously you and I worry about the uptake in care homes, particularly over the winter season. But I mean, there are other vaccines here that can be given any time, isn't there? So there's that to think about.
Yeah, thanks, Mary. I was going to cast my mind back probably just over a year or a year ago, where we were looking at data around uptakes. And I think our system was a little disappointed with where we got to. But I'm only saying that in as much as the shout out that should happen for, I don't think there's any bad news at all in any of this report. It's honestly fantastic to see those numbers go back up. And I thought it was really worth shouting that out. So we found a problem and everyone has really embraced that. And I see the UHP numbers went up because they were, so across the board, that's a really good thing. And I think on your point, Mary, what I also like is you're already talking about how we can keep that approach to drive all the other numbers up, so that the vaccines through the year. So all I wanted to do really was shout it out and say thanks, because that is such a good bit of work, and how important we know these vaccines are, particularly around winter, but actually, you know, all year round for some of our groups. So thank you.
Aaron.
Just a quick question. Is there a way of disaggregating the total uptake so you can identify which ones had a better uptake than others and which maybe to target?
I think for the children in care data, that's the one where we were talking about it's not disaggregated by vaccine. So we could do that if we were able to review the GP level data. The difficulty we've got there, to be honest, is it's quite small numbers, and we wouldn't want to take the numbers so small that we could identify individuals. But I think if we're looking more widely at the patterns of vaccine uptake, we know where some of or we know which vaccines where there's a bit of a kind of shortfall in terms of uptake. So I think if we do that targeted work by vaccine, that should help us to kind of nail down some of that detail, because it is difficult to split that out. We don't actually record it by vaccine for children in care.
Jemima.
Apologies, I had to go out. And this may have been asked already, but about the HPV vaccine, I mean, to me, that is, you know, one of the most extraordinary things that's happened in my lifetime, and is en route to eradicate cervical cancer. And so I note that it's, you know, you want to improve uptake for that. And I wondered whether other places, you know, what's the most effective thing that gets somebody to be vaccinated, or for their carer or parent to think that's the right thing for them to do? What's the real nudge thing that happens that makes people do it if they're reluctant? And what innovation is there in this space, and what can we grab or, you know, borrow to keep improving those numbers around HPV vaccine?
Thank you. Yeah, agreed. Super important. To the next board, we'll bring a cervical cancer elimination strategy kind of update for you all, which reflects some specific work on HPV. The work we've done so far is trying to get to the crux of what is it that's affecting the HPV uptake in Plymouth children. To be honest, some of it is around kind of administrative stuff, you know, the immunisation provider in the school and how they communicate and share information. So some of those things I think are there for us to navigate, sort out. A lot of it is not about a hesitancy or a reluctance to get vaccinated. A lot of it is also parents, you know, filling in the form when it's sent by the school, and having time and capacity to do that. And then, you know, organisation on the day. And so lots of it, I think, can be addressed with some of those very practical steps. And then there's quite a lot of innovation around HPV vaccine in terms of how we engage with those people who are feeling unsure about the vaccine or would like more information and that kind of thing. So there's some quite innovative kind of education packages that can be delivered in school settings and so on. And I think those are worth exploring. I'm really conscious of the challenge that all of our schools have in terms of kind of capacity and ability to engage with some of these wider health challenges. And I think that's really tough for them. But there's a lot of enthusiasm, and the school-aged provider for immunisation has also been commissioned to do educational work. So they're doing work such as speaking in school assembly, engaging the children in an understanding around what this vaccine is and how it might help them as they progress through their lives. So I think that there's lots and lots of different bits and pieces that we can be doing. And there's lots and lots of evidence out there from other settings. So yeah, really valuable point and completely agree. Yeah.
And I note that you're working with the Youth Parliament as well, and they've got a lot of clever brains in there. They're very good at coming forward to help. One thing, I don't know if I've missed it and whatever, but meningitis in vaccination. They used to do that for first year students or new students coming into the uni because of all the strange bugs that they would then have within their sphere. Do they still do that?
Yeah, so there's a meningitis offer for teenagers, and so that's also offered through the school age IMS. But we're aware that that's not always kind of consistently taken up. So what we also have is the vaccination outreach team do outreach into freshers fair at the university and so on to kind of pick up on that kind of later teens group and offer catch up. So yeah, I don't actually have the data with me today about meningitis vaccine uptake, but we've lost the screen. But yeah, there is work ongoing, but we'll take that away. Actually, Mary, thank you.
Only we've lost the big screens at the moment, so we can still see you, which is lovely. Out of curiosity, has Healthwatch ever done any look into vaccination stuff, or is that something that you haven't done?
No, I guess we haven't done any specific work around vaccination uptake. However, in the past, we've been involved with the ICB and the vaccination team there about messaging for seasonal vaccination, so predominantly around flu and COVID. And that, but in terms of actual engagement work around take up, no, we've not done anything. There may be a Healthwatch England national report. I'll have a dig, and if I've got it, I'll send it to Elliot to push out to members of the board.
Thank you. Yes, that would be interesting reading. Anybody else got anything right now? Sorry, we got the screen now, so you're back with us, Rob. Did you want to ask any questions?
No, I think that's fine. No, just to say that we have vaccine clinics in the Wellbeing hubs on a regular basis, and we do a carers vaccine special drop-ins as well.
Reading this, I did realise that there's that opportunity for carers of somebody that's immunosuppressed, etc., to get vaccines. So that's really useful to know, isn't it? So that may well be something that the Senior Citizens Forum might well be interested in as well. Okay, right, now, Teresa, you want to say something?
Yeah, sorry, just to come back on 2 points. So also just to supplement what Tony said, one of his Healthwatch colleagues, Tanya, was also very helpful in engaging with community members for us around issues that were kind of being barriers to taking up vaccines with parents. So that was actually really, really helpful. She fed back some material there. And also just on the point around carers, Mary, just to add to what's in the update, we did do some targeted work on social media around carers. So anybody who had searched for or engaged with information around carers was then kind of the cookie then targeted those individuals with our messaging around how carers were eligible for a vaccine and encouraging them to go and take up their vaccine or be in touch with their GP. So we also did an additional piece there around carers.
Great stuff. So the recommendation for this, the purpose of the report is to provide an update on the activities undertaken to improve vaccine uptake, provide insights into their effectiveness and outline future actions. So can I ask you to note the report, folks? Thank you very much indeed. Brilliant. Now, this one is a really interesting one. We did have somebody in a meeting that I was in that sort of made comment about there's nothing for men and boys. It was sort of looking at women's health. So this is really great, and I'm really pleased that you're able to bring this today. While Elliot looks for your name, would you like to introduce yourself?
Thank you, Chair. My name is Sian Rees. I'm a public health registrar in the public health team at Plymouth City Council. Thank you for having me today. So today I'd just like to take the opportunity just to share with you really the first national men and boys health strategy for England that was published in November 2025. And to really briefly contextualise the problem in Plymouth really, and to give sort of that higher level context. In England and in Plymouth, more than a third of men will die before their 75th birthday. And that's the life expectancy for men in Plymouth is much worse than the national average, but also nationally we perform worse compared to other high income countries across the world. So there's a real challenge. And with respect to life expectancy, the proportion of that time that men spend in poorer health is quite stark. So around a quarter of men's health is often spent in ill health. So there's a real opportunity to be making efforts to improve that. And as we all know, deprivation really profoundly affects how we all experience health. And for men in Plymouth, deprivation has a particularly strong effect. So the difference between the life expectancy for a man in the poorest area of Plymouth compared to the wealthiest is 10.4 years, which is a real stark inequality. And the data on the right-hand side of the screen explains that difference. So for those men in that experiencing that sort of inequality, circulatory disease and cancer are the sort of the leading causes of that, but also respiratory disease. And in those sort of smaller categories at the bottom, as we've already heard today, suicide is an important contributor, but also death and injury in the workplace also contributes quite significantly for men, which is, as you can see, very different how that looks for women. So important areas for us to focus on. So the national strategy for England really broadly has a vision that we set out to improve health outcomes broadly for men and boys. It's quite a smart strategy in that it's responding to persistent evidence that men are more likely to die from preventable causes of ill health, but they're also less likely to seek health services when they need it, less likely to engage with community services, which impact upon that social isolation, that wider support services that we all need to sort of maintain our health and well-being. But also men are more likely to be involved with behaviours that are more likely to be damaging to their health. So things like smoking, alcohol use and drug use. So the strategy aligns quite strongly with the NHS 10-year plan. So as we've seen, we've had that shift from hospital to community, from digital to analog to digital, and from treatment to prevention. So this really resonates with everything we've been hearing today and all of our ambitions really for the board in terms of improving health for our population overall, but also for men and boys. And the strategy proposes 6 levers in which to address these aims. So the first is improving access to healthcare for men and boys, supporting those individual behaviours we've spoken about, those harmful behaviours to health. Developing healthy living and working conditions, fostering those strong social, community and family networks, addressing societal norms, which is tackling harmful male culture, but also that violence against women and girls, and then broadly tackling the health challenges and conditions specific for men, in particular things like prostate cancer and cardiovascular disease. The strategy does highlight a couple of vulnerable groups, but it's the groups that sort of are vulnerable across most health conditions. So looking at rural areas, coastal areas, prison communities, and care leavers, men in contact with the criminal justice system. It's all of the usual vulnerable groups that we need to keep in mind as we take forward a men and boys health strategy. So when I was thinking about what work we already do to map against this strategy, as has been really helpfully highlighted today, there is a lot of strength in the Plymouth City Council's and public health's activity, which aligns with the men's and boys health strategy. We have a really strong commitment to suicide prevention, as we've already heard today, a really strong community-based provision for men and boys. There's a huge network of family and wellbeing hubs, youth clubs, sports groups, men's groups, who are all working to meet men where they are and to engage with men in the local communities to support them to live happier, healthier lives. There's also some work being done to address the societal norms. Plymouth City Council itself adopted the It's Time to Change man culture provision of services, which is being adopted by employers throughout the country, throughout the city. And we're also taking up programs of work where we're targeting any intervention for high-risk behaviours, so including the alcohol liaison teams and emergency departments, and also targeting people, but specifically men, who are attending the emergency department with, for example, chest pain, where we can proactively support men where they are when they're needing that help. And we've already heard examples today of where community services have been in with employers to try and grab those men where they can, because we know that they're not coming to us. And our 6 priorities that we've adopted today for the Health and Wellbeing Board to take forward, as you can see, directly align against this strategy. So it's a real success story for me that we already are doing quite a lot in this area. There are some opportunities for us to do a little bit better. We have a really strong data intelligence team and network across the city. However, sometimes that sex disaggregated data isn't necessarily as visible as it could be. So, for example, vaccination uptake for influenza virus. Do we know if men and women are behaving differently in terms of, for example, uptake of vaccinations or the NHS health checks? We could make that a little bit more visible, as we could do with all protected characteristics. We could also ensure that, as we already are doing, but more targeted uptake for men and boys is taken up of things like NHS health checks, and those offers that we have that we're already putting out there that are strong, that we know are evidence-based and are working really well, that we're taking that out to men and boys where they are. So maximising on employers and recognising ourselves as employers, as a council, as health providers, as with the military, and recognising that we could lead by example and taking what we offer already to men and boys where they are, and using our links with the sports and leisure centres and clubs to try and further maximise upon our offers that are there. And whilst our community engagement is really strong, we have highlighted that particularly for young boys and for young men in particular, that can sometimes be quite difficult for them to engage with. So we're already taking work forward to look at how we can make that offer a little bit more attractive for them or meaningful for them, so they can engage more with what we already offer, because they're coming to us but potentially sometimes not staying because perhaps the offer isn't there. And then finally, a new opportunity for the next year is that we have the statutory gambling levy, which is moving forward, but that's a real opportunity as well to tackle a very specific problem that affects men and potentially young boys who are engaging very differently with the online world than what's been previously experienced. So it's very difficult to encapsulate everything, because everything we do affects the entire population, and 50% of that is men and boys, and we already do so much. So it's really about thinking smartly about what makes men and boys different in terms of how they behave and how they engage with health services and community services or don't, and how we can really maximise upon what we have already, which is a strong offer for health, to really ensure that it's meeting the men and boys that we need to, and really just the ask that we can be men and boys health ambassadors, really, and not that we necessarily need a very specific program of work for men and boys, that we really think about those principles of health inequalities, that not everyone experiences health differently, and that is true for boys and men. So, thank you.
Thank you. Really interesting and very apt when you think Saturday is the men's day out for St. Luke's, isn't it? And that's always a very good, yes, some of them stop various places on the way and they're perhaps not walking so straight by the time they've finished. But, it's a good way of bonding, isn't it? And sort of meeting new people. I'm really interested to see about the men's support groups. There are so many there that I certainly did not know about. So I'm just wondering, how do we share that with everybody that goes onto the council's website? You know, we've had lots of sort of plans for women, and then you get that, oh, there's nothing for me. So we need to be making sure that people know that's on. One of the things that I do think we ought to check at the moment, Tot Hill Community Centre is out of action due to a problem. So it's really, I'm going to take it up with Elder Tree that where are they meeting instead? But I think we need to be aware of that. But they're great, aren't they? Absolutely wonderful. So anybody else want to share things? Rob, I don't know if we have to say you need to declare an interest, because I'm sure your organisation is helping to run some of these.
Well, I was just thinking actually about the veteran population in the city. It was approximately about 18,000 people. About 88% of those will be male. Veterans being notoriously suspicious of engaging with a lot of mainstream services. And I know a lot of our organisations in the city have done veteran friendly awareness accreditation, particularly PCNs and Live Well in the hospital. But there's something about actually reaching out to people at a grassroots level. And we do have a really good ecosystem of organisations working with veterans in the city. So I'd be really, and we've got our own men's shed over at Ernest English House for veterans. So I just wonder whether there's something there about some public messaging directly to that cohort of organisations and out to veterans in particular, because I'm sure I could find some data which would be very revealing about men's health in terms of veterans. That would be well worth exploring.
Thanks, Rob.
So happy to have a conversation with Sian out of this meeting.
Excellent. I know I've been invited by Glenn Jordan to go to Fulston Park to speak with veterans. Yeah. One of the things that I'm not too sure, do men react better to males going to share information than females? I've never really thought about that before, but it might not be the thing to do. I think we might have to think about that.
Thank you, everyone. Thank you, Chair. I think sharing the offer that we have is probably one of the most important things that we can do. I completely agree, and that'd be really helpful, Rob. It'd be lovely to connect. And when I was pulling together what's available already, I know I've shared the men's support groups, which Martin, our community builders, the men's health community, he's fantastic. That's only a small chunk, a small part. There's support groups for men experiencing mental health problems. There's the veterans community groups. There's the LGBTQ plus groups. So there's a huge offer, and through the family hubs, there's a very strong offer for dads and for new fathers. So that but I think you're right. Communicating that offer is so important, because it's very difficult to access that offer and to know where to find it if you're not already engaged in that space. And in terms of how to communicate this better than men and how to communicate, but I think I'm not, as a female, I'm not sure. I've had some conversations with Andy's Man Club, and I think for some men they do feel like it's better coming from men, but I'm not entirely sure. But I think it's probably a good place to go and look at the literature and see and just speak to men and ask what works best for them.
I'm going to ask Jemima to come in here, because she's a much more a comms guru than I am. I just wondered your view about how we could get this over. I mean, yes, I could make an announcement on Monday in council to say that we've received this and we're working on it. I just wondered what you thought.
I don't know. I mean, because one of my questions was going to be around social media, and obviously quite often the answer to comms dissemination is social media. So I'll think about your question. Do you mind if I ask my question? I've got two questions. One is the kind of read across to education in terms of attainment and how that feeds into this plan. And obviously that, there is a disparity around attainment and a gender-based disparity, and how that feeds into this plan in terms of healthy life outcomes and prosperous futures and all the rest of it. And also I watched, last night I watched because social media has kind of got a glancing mention in here, but I watched Louis Theroux's documentary about the manosphere last night. And I just think in terms of mental health, how that whole world of those kind of influencers are talking to really quite young boys actually, and just how that plays in terms excuse me, of their mental health, and their expectations and their aspirations and also their place in the world and how they interact with women and all the subsequent kind of issues that arise from engaging in that world. I just wondered how that could be reflected in the plan, because I think that is going to be a big part of particularly younger boys and men as they grow older and go through the world, the impact of that and how that is reflected in here.
Thank you. So the strategy, which is it's one that they've nationally put together, they didn't really touch on education or attainment. There was sort of a nod to it, but I think it's something that wasn't really a strength of the strategy, really, but obviously really important and something that I think you're right. It falls as part of those wider determinants of health, doesn't it? And that for boys, education is so protective and important for, like you said, those future aspirations. And I completely share your concerns about the manosphere and just social media more broadly. I don't think we have a strategy really to sort of tackle that, but I think part of that for me is around engaging boys in a meaningful way in their communities and in a more face-to-face way, and having those strong family connections. I feel like it's such a complicated puzzle and web, so if you have the right family connections and supporting families, then you'll create the family ties that are important for those foundational years, and having the right conversations at home around values and what's important and aspirations, but then having the right training for schools. So I know schools are tackling this, and I think we really need to support schools to do that, but also to support families to do that. And then there's obviously that national conversation around social media and whether the ban will or will not go ahead. But it's difficult, isn't it? And I think, but it's something that needs to be a priority, particularly for boys and young men.
I mean, now we've got this plan that's come out, it gives us that ammunition to go out and talk to more people, doesn't it? And sort of see how we can manage it. I think, obviously, the council staff are an easy hit to make sure that they realise that this is on, but then working, and again, it comes back to going to the youth parliament, doesn't it, as well, and having that discussion with them, because they have a lot of energy about domestic abuse, etc., and this would then help to fit in with that, wouldn't it? So that would be good. Gary.
Thanks. I just want to say firstly thanks, although it's quite stark to read, and I think nationally the picture is there, but you show Plymouth as even worse than that for men. And I think we touched a little bit. I was really interested in that generational piece, but I was also thinking about some of the historical campaigns around not smoking or healthy eating, where the younger generations became a really powerful either motivator for parents, wasn't it? I remember the non-smoking ones about spend time being active with your children and all of those things, and just the thoughts around that and around what happens in that space, and whether that's a lever that's trying to be used as well.
Thank you, Gary. I completely agree. And it seems we have to be smart, don't we, and adaptive and flexible, and drawing on the success of those. And I think the Olympics was another one, wasn't it? And I think what came through in all of my time looking at this and experience and talking to everyone is that sport seems to be a real protective factor and opportunity. So, for example, the World Cup coming up, and the interest and energy that everyone has, but it not only brings everyone together, but it also generates this interest in getting involved yourself with sports and things like that. And like you said about that, doing things together, and I think those are the opportunities we should be really leaning on for men and boys in particular, just because they already have that space in with football and sports. But yeah, I completely agree. I think we have to be smart about how we approach that.
Tony, do you want to come in?
Yeah, thank you, Mary. This is more of a personal reflection. Very interesting report, I think. So, firstly, I'm a veteran. I left the service in 2013 after 37 years. And my experience of veterans, they tend to fall into two groups. Those that leave the service, make a clean break and kind of get on with their lives, will interact generally and do things. And then you've got a core of veterans who are very insular because they brought up in that service fraternity. They've got their mates and comradeship, and they lose that. And those are the ones that tend to, I think, struggle. And they struggle both to reintegrate into a more civilian society, but equally, how do they keep relationships going? And equally, communications. I don't use any social media, full stop. I'm probably not unique in that, but I think from a communications front of view, you've really got to think of all options available to get a message on, to get support to people, and whether that's by flyers on public notice boards, whether it's utilising services out there to help, gender information that can be passed by word of mouth or whatever. It's not going to be an easy nut to crack, I think, and I think that's because we're blokes. Fundamentally, we have that sort of self-sufficiency within us. We don't want to talk about things, and we're quite happily just ploughing along, getting on with things. And if we get ill, we may go to the GP. So that's kind of a bit of a personal reflection.
Thanks very much, Tony. Anybody else? No, right. So I need to ask us that the Health and Wellbeing Board review and comment on the men's and boys' health paper. Obviously, if there's anything that jumps out at you that it's missing, we'd love to hear from you. And that the Health and Wellbeing Board endorse the proposed next steps for local action on men and boys' health and inequalities. Are we all happy with that, folks? Can I have a quick show of hands? Yeah, excellent, excellent. Thank you, Sian, very much indeed. Fascinating. And let's see what input there is. And obviously, if we think of any other things that you could try, we'll let you know with pleasure. But I think a report back to us, maybe halfway through the year, as to where you've got, might be quite a useful thing. Okay, thank you very much. So I now hand over to Elliot.
Thank you, Chair. Turning to the tracking decisions log, members will notice that there's quite a top-heavy section that are in progress rather than complete. Obviously, our last meeting was only mid-January. What I propose to do is chase as many of those towards the end of this municipal year and provide members with a rounded picture, the latest update basically before we go into the pre-election period. I'm happy to try and take questions on them, but obviously noting that a lot of those at the top are in progress. I have had several updates since, and I will circulate that to members. And the last one on the list is currently on hold until the appropriate time, so that links into work programming. But I'll take any questions if members have got them. Thank you.
No hands up. So next one. Sorry, Gary's.
It's just a small point, Elliot, but I just know from some staffing changes that are going on that we might need just to connect to make sure you're chasing appropriate people to get responses. Oh, have you? Okay.
Then work programme.
Sorry, thank you, Chair. So in terms of thinking about the work programme, we'll obviously pick up at the start of next year. We've now got our new agreed priorities to try and link in. So I suggest we meet in the new year informally to try and work out how we link those into programming for the year, whether that's taking a couple of themes per meeting or whether it's spreading them equally across the year. We have got a number of items on the work programme, sort of residual from this year, includes avoidable death review, cervical cancer elimination strategy, local care partnership priorities. What I suggest is members have got that list, we'll link up and work out which themes they all fit into and try and organise it by that. Thank you.
Yes, and I also think we need to consider how frequently this committee or this board meet. And so I think there needs to probably be, I say, a round robin as to find out, and whether if we, for instance, mimic the ICB, they have one meeting in private, then the next month it's a public meeting. So are we, would it be good to have a private meeting occasionally to iron out lots of things that we need to do? So I think we just need that dialogue as to how often it will meet, since we've got such a large agenda to look at with those six themes. Okay, we'll get back to you on that as well. And maybe to keep Michelle happy, we have a different day for some of them than others. Okay, thank you very much, team. And that's it. I declare this meeting closed 6 minutes early. Cool. That's very cool. Take care. Thank you, everybody, for your taking part, and thank you for your support over the year. It's really been valued, and I think we've made quite a good progress with some of our themes. So, thank you, and hopefully see you next civic year. Bye.
Thank you.